Second, just to start that. ആണോ സൈറ്റിൽ നോക്കിയാൽ ഓക്കെ ഇപ്പോൾ വരുന്നുണ്ടോ? ലൈവ് ആണ്. So there is some 5 minute delay. Like when I start, it will start up only some 1-2 minutes. Delay start.
delay की बात ही नहीं कर रहे सर, बोलने की आई नहीं। हेलो हाँ सर, अभी शुरू करेंगे सर, अभी शुरू करेंगे तो देयर इज अ डिले ऑफ 1 to 2 मिनट्स, उसके बाद आना चाहिए। थोड़ी देर में अभी स्टार्ट कर रहे हैं, 2 मिनट के बाद आ जाना चाहिए सर। देखते हैं, मैं आपको कॉल करता हूँ। अभी है ना, अभी स्टार्ट कर रहे हैं सर, 2 मिनट के बाद
आ रहा है। Yeah. Sir, shall I start? Yes, 10:24, sir. Yeah, 19. Sir, 25. Sir, 25. But respected faculties, seniors and my dear juniors, I am Dr. Sailik Palagurchi, JRN 5th semester. I'll be presenting on acute respiratory distress syndrome. My moderator for this presentation is Dr. Prakash sir, Department of Emergency Medicine, AIIMS New Delhi. So our objectives during this presentation would be going through the definitions. What do you mean by phenotypes? The role of high flow nasal oxygen, PEEP strategies, lung recruitment maneuvers, prone positioning, neuromuscular blockade, extracorporeal support, corticosteroids and fluid management. We'll be talking some of the evidence that is relevant in the context and the recommendations given by various clinical practice guidelines. So, first disclaimer, this is not a definition, this is just an introduction to the topic acute hypoxemic respiratory failure or acute respiratory distress syndrome. That is due to lung inflammation not caused by a cardiac cause, cardiogenic pulmonary edema. So what does this entails? It entails a spectrum of condition with different clinical etiologies which share a common clinico-pathological characteristic. We will be discussing each. So what happens in an acute hypoxemic respiratory failure or ARDS? So there is some etiology that is leading to increased permeability of the alveolar capillary membrane that result in an inflammatory edema. At the same time, there is an increase in the non-aerated lung tissue due to atelectasis and other causes leading to a lower compliance of the lungs. And this leads to increased shunting, increased venous admixture and dead space that result in hypoxia and hypercapnia. So before going into specific definition, I would like to show you how it stands in the world. So this is taken from LungSafe study. It was conducted in 50 countries, in 5 continents, in a lot of ICUs. So 10% of admission to intensive care unit constitutes the current prevalence of ARDS or incidence of ARDS. In admission to ICU, 10% are ARDS. Or of the all ventilated patient, 20-3% of the patients are ARDS. And the mortality have been reported up to 45% in the severe category. Let us see what does similar data in our country suggest. So this data is taken from 2 studies. One was conducted in CMC Vellore and one was in Kasturba Medical College in Karnataka. So similar to the world incidence, in mechanically ventilated patient, the incidence of ARDS was 11.4%. And in India, the most commonly identified etiology was sepsis, which is an indirect cause. That is 36.4. thing to note here is the mortality of those in ARDS was 41.8 and 44% in the respective studies, comparable to mortality that have been reported in the world standards. This is a pictorial representation of the various etiologies that have led to ARDS in India. Specifically, this study was taken from the study that was this data was taken from the study that was conducted in Karnataka. As you can see, pneumonia is still the number one cause, followed by scrub typhus, which you won't be seeing in other world literature, other countries' literature, less likely. Followed by unknown source of sepsis, followed by abdominal sepsis, then broadly non-septic causes, leptospirosis, H1N1, malaria, skin infection, pulmonary TB, which has very low percentage, and dengue fever. So as for a comparison, like how does our health standard compare with the standard of care in America? So there also the in-hospital mortality was 38.5%. We also have like 41.8 and 44 in two different studies reported. So that shows that we are practicing evidence-based up-to-date care. Additionally, they had reported that with increasing age, there is increased incidence of ARDS. Like 16 was in the age group of 15 to 19 years of age, and 306 was the incidence per 1 lakh person years in 75 to 84 years of age. So coming to ARDS definition. So here I would like to ask a question to Pawan. Please, can you answer? You have a patient who presented with respiratory distress. You did all initial investigation. Initially, patient was hypoxemic. You started the patient on NRBM. Patient was not maintaining adequate oxygen. You started the patient on HFNO. You don't, etiology, whatever it is, you started the patient on HFNC. You keep the flow at like some 25 liter per minute. Rest FiO2 at 60 to maintain SpO2 above 92, suppose. So currently, how do you diagnose an ARDS? What do you consider as a prerequisite for diagnosing ARDS?
It's the acute onset of the
Hmm.
in 1 week of the and also like we calculated PF ratio.
PF ratio, for the calculation of PF ratio, do you have any prerequisite?
Yeah, we need
PEEP of 5. You need a minimum PEEP of 5. So this patient which I had mentioned right now, do you consider him to have ARDS? If he have 1 week of onset, his X-ray had bilateral opacities, his PF ratio was also less than 300, but he was not on positive pressure ventilation. He was kept on HFNO. Will you consider this patient to have ARDS?
it's the one limitation in the
So thank you. Please sit. So coming to acute history of ARDS. ARDS have a history of approximately 60 years. It was first described in 1967. Later they tried to quantify it based on the physiology of respiratory impairment, like the lung injury score. I'll be discussing in the next slide. Then there had a consensus between American and European societies in 1992. And finally in the Berlin Convention, they had made a Berlin definition. I'll be discussing all the significant ones in the upcoming slides. In 2016, some limitation of the Berlin definition was highlighted and there was a proposed Kigali modification for resource limited setting. And 2024, sorry, that's a typo. 2023, the manuscript was sent. 2024, January, May, it was published. A new global definition of ARDS, which we are currently following. So coming to lung injury score, this is not anymore used for diagnosis. Only use this can be done is you can use this to see the severity of the disease. Like,
Sorry, yes. What is the major difference between vertical and vertical?
sir, I haven't discussed, sir. I've just described the timeline. I will come in detail to everything, sir. So this is the lung injury score, the Murray score which we have. It has 4 broad components. You add all the components and divide by the number of domains that have been involved. Like suppose you have 4 in all, you will get a score of 16. You will divide because you have involved 4 domains. So 16 by 4, your lung injury score will come as 4. That is will come as severe lung injury category. So this was the second severity of physiology and respiratory impairment. In 1988 it was described. Even though it cannot be used for diagnosis anymore, it can still be used for disease severity classification. So this is the Berlin definition which our Ashwin had, Pawan had told. So it was in 2012 by European Society of Intensive Care Medicine. The symptoms begin within 1 week of insult or new or worsening symptom in the last 1 week. Bilateral opacification on chest imaging, PF ratio less than 300 when PEEP is more than or equal to 5 centimeter of mercury, 5 centimeter of water, and not fully attributable to cardiac failure or volume overload. This is what we know. But like you can see, this has various limitations. PEEP is not always available even in research-rich settings, like our setting. You cannot give PEEP to all patients to diagnose whether the patient has ARDS or not. Imagine a resource-limited setting who doesn't have a VBG, who doesn't have a NIV, who doesn't have a ventilator. How will you measure PaO2? That is also, does this mean resource-limited setting does not have ARDS? No, of course they has ARDS. We are just not able to diagnose it. And what does not diagnosing a disease lead to? It leads to worse mortality and loss of data. We won't know what is happening to those patients. That's why in 2016 Kigali modification was proposed, even though it was not adapted in as an official recommendation. This was what it entailed. Like it said that you do not need a positive and expiratory pressure, and it also included lung ultrasound as a modality for bilateral chest involvement. Lung ultrasound, the beauty of that is not all centers have X-ray or CT, but a lot of centers have mobile ultrasound units and a lot of things like that. So that's why lung ultrasound was included to address the resource limited settings. Similarly, hypoxia, rather than defining a PaO2 FiO2 ratio, they defined a SpO2 FiO2 ratio, and the cutoff was taken by as 315 by comparing the PaO2 FiO2 and the SpO2 FiO2 graph. One condition here was that when you are using SF ratio as a cutoff, you should always maintain the SpO2 less than or equal to 97. Why do you think that is needed? Why can't I keep when the SpO2 is 100% and use the SF ratio?
PaO2 may be higher than 100%.
Yeah, it is because of the characteristic of the oxyhemoglobin dissociation curve. You know that above 97% there is that plateau phase. So you won't know how much PaO2 is correlating with that particular SaO2. But up to 97 it has that graph. So that is why 97 was kept as a cutoff. So this is the, you don't have to read it, just the paper so that you know this is the paper. So the new global definition of acute respiratory distress syndrome, it came in 2024. So let us see what is their conceptual model. It is the same concept. It is the same conceptual model as the conceptual model of the Berlin definition. They haven't done much change to the conceptual model, that is how the pathophysiology, how the ARDS develops and all. Simply what you have described in the first slide, acute diffuse inflammatory lung injury precipitated by a risk factor. We will be coming to what are those risk factors specifically. This lead to pulmonary edema from an increased permeability and gravity dependent atelectasis. In the end, it leads to an overall loss of aerated lung tissue. That is the conceptual model. So what are the clinical hallmarks of ARDS? So the first two though we know for sure: arterial hypoxemia, diffuse radiographic opacities. Because of the loss of aerated lung tissue, what happens? A lot of blood gets shunted. It won't get aerated, it will just go from right ventricle to left atrium directly. So there is increased shunting. Similarly, increased alveolar dead space because of collapsed bronchus, and there is decreased lung compliance. Histological findings, even though it is not a necessity for diagnosis, it is better that you know rather than not knowing it. So intraalveolar edema and inflammation can be seen, hyaline membrane formation can be seen, and alveolar hemorrhage can be seen in a diffuse pattern. Not so much important in our clinical setting or in an emergency setting. So these are the risk factors. What highlighted in red are most common risk factors, and the rest are still contributing risk factors. So risk factors can be broadly divided into direct and indirect lung injury. So direct lung injury means the pathophysiology itself is in lungs, like pneumonia, aspiration, contusion because of trauma, embolism of fat or thromboembolism, near drowning, toxic gas inhalation, and after lung transplantation or embolectomy, you have a reperfusion edema. What are indirect injury? There is some pathophysiology happening in somewhere else in your body, and then that is leading to some hyperinflammatory state in your body, and that is leading to your lung injury, like in sepsis or trauma not to the chest, to the other place, but the patient is in severe traumatic shock, or there is a transfusion associated lung injury, or secondary to acute pancreatitis, burns or disseminated intravascular coagulation. So now coming to our definition. Definition has three components that is common across all the defined subtypes of ARDS. That is, one is origin of edema, one is the timing of the symptom, and one is the chest imaging. And then we have different categories like non-intubated ARDS, intubated ARDS, ARDS for resource limited setting. So to consider those three categories, first you have to ensure that this is fulfilled. So first you know origin of pulmonary edema, that should not be primarily attributable to, that word is important, primarily attributable to cardiogenic pulmonary edema or fluid overload, atelectasis or lung collapse, pleural effusion or pulmonary embolism. This doesn't mean that if a patient has pleural effusion, that patient cannot have ARDS. It is basically your clinical gestalt that you decide whether, or you conclude that this hypoxia and this respiratory failure is primarily not because of that pleural effusion. That will depend on your clinical expertise. Similarly, it's not like a patient with COPD or ILD can never have ARDS. If it satisfies that patient has an acute onset respiratory distress with the precipitating risk factor that have been worsened in 1 week, that you think is not primarily caused by the underlying condition described here, it can still be ARDS. So the timing, they haven't changed the timing, that is acute onset or worsening of hypoxemic respiratory failure within 1 week. So one consideration here I would like to discuss is, during their panel discussion, they had a debate on whether to increase the duration of ARDS from 1 week to further, considering that there are multiple etiologies that may have an initial indolent course and then later frankly they'll develop present as acute hypoxemic respiratory failure. But then in the end they voted against it because since they have already included high flow nasal oxygen as a criteria for ARDS, they said those high flow nasal oxygen is likely to pick up those indolent cases of ARDS, so there is no necessary need for increasing the duration from 1 week to further. Chest imaging, we'll come to images separately. This I've just kept small icons for quick reference. So either you can have bilateral opacities on chest radiograph and or computer tomography, like you have bilateral non-homogeneous opacification of the whole fields that is seen in this chest X-ray, or you can have bilateral B lines. Here it should be taken with a pinch of salt. What is the Vivek, what is the focus finding of cardiogenic pulmonary edema? Bilateral B lines. So how would you distinguish? It's a really hard thing. They have mentioned multiple times the operator should be trained, it should be based on that. But one thing that you can see is bilateral B lines in non-dependent areas. That is one thing that is not likely to be caused by cardiogenic pulmonary edema. And or consolidation, that means the etiology is in lung itself. That is, you have shred sign, you have consolidation, hepatization, all those signs if you are feeling, then you can consider that. But they haven't clearly mentioned that these signs can be taken as ultrasound finding. It is in the end a clinical gestalt of the clinical presentation as well as the ultrasonography findings. So here, just for a reference, we can see the CT, the cut section of a CT chest of a patient, of 2 patients with ARDS. In one, you can see there is focal involvement of dependent areas in this patient, and in that patient there is diffuse involvement involving the whole fields. So this these are actually 2 different phenotypes of ARDS as well. We'll come into it, but just to show that how the ARDS picture will look like on a CT scan, it is not different from your any infection or pulmonary edema. It will be hard for you to distinguish. It still depends on your clinical presentation. Or an ultrasound, like we have already discussed, there can be diffuse non-homogeneous opacification involving the whole lobes, or it can involve just one side. It can involve just depending on the involvement of the lungs. And ultrasonography, we all know the findings, but just to reinforce it. So I'll play the video separately since it's not loading in this.
These are B lines. So this is the pleural line right here, and you can see these vertical artifacts starting from the pleural line, extending all the way down.
So
this implies that the patient has pulmonary.
So this is, you all know this, just for reference I am showing this. You can see the B lines, there is thickening of the pleura, everything you can see. Or shred sign also. You can see there is proper shredding of the pleura that can be seen here with some amount of hepatization here. There is some pleural effusion also associated with it. So such ultrasonographic signs can be found on your ultrasound examination. So just quickly going through some clinical, some radiological things that can help you distinguish between heart failure and ARDS. So usually ARDS will have a rapid onset. Precipitating factors of cardiac will be the cardiac causes like myocardial infarction, valvular diseases, things like that, whereas the causes which you have discussed will be the precipitating factors of ARDS. The JVP will be usually raised in cardiac causes, but it can or cannot be raised or mildly raised in ARDS. And peripheral edema is common in heart failure, S3 gallop is common in heart failure, cardiac history will be present in heart failure, B-type natriuretic peptide will be significantly elevated in heart failure, but normally or mildly elevated in ARDS. And response to diuretic, the patient will usually respond to our diuretic therapy if it is heart failure. So radiographic features, there can be cardiomegaly that you can see if it's ARDS. There will be prominent upper lobe vessels, cardiomegaly if it is heart failure. Similarly, there will be prominent upper lobe vessels when it is heart failure. Curly B lines are more characteristic of heart failure. Pleural effusion is common in heart failure. And the pattern of appearance of the pulmonary edema, you have the characteristic back wing appearance or something similar in heart failure. Air bronchograms, that is more associated with your pneumonia, will be common in ARDS, and the lung compliance will be severely decreased in ARDS. And these are some of the things, these are not an exhaustive list that contains everything, but some of the things that can be used to distinguish between cardiogenic pulmonary edema and acute respiratory distress syndrome. So the lung ultrasound, it can be patchy asymmetric B lines rather than a uniform picture of bilateral B lines. Pleural line can be thick and irregular, and a subpleural consolidation can be present. With heart failure, you have pleural effusion, you will have a LV dysfunction, and you will have a full inferior vena cava, and pericardial effusion may or may not be present depending on the etiology. So now coming to three type of ARDS. We have a non-intubated. Yes, sir.
One more point, additional point is, is focusing on nowadays, you have AI generated, B-line score.
Yes, sir.
It is very important for you when you are managing ARDS. You can do a baseline lung score, and automatically it will give you the B-line score. When you manage ARDS, so for improvement, you can do repeated, B-line scores and to see the progression of your management.
Yes, sir.
Both for if you are managing pulmonary edema, cardiogenic, you have to do it quickly.
Yes, sir.
If you don't have, you can just scan it and see. But since if you have the machine, B-line score, start doing it.
Yes. So just giving a small idea on what is this lung score. You divide the lung into 6 zones bilaterally, 1, 2, 3, 4, 5, 6, like bilaterally you do, posteriorly, anteriorly and laterally. Then it has score of 0 if it is pura A lines, score of 1 if it has single B lines, 2 B lines something, and if there is multiple B lines you give a score of 2, and if it is coalescing B lines like waterfall like phenomenon you give a score of 3. So out of 36 you score the lung score, and then you see for improvement according to your therapy or things like that. That is what Sarah emphasized. So in ARDS also you can do a baseline lung score, you can do it manually with your eye, or if you have an AI enabled machine, just to keep the probes in 1, 2, 3, 4, 5, 6, it will give you a lung score. So it is a very easy thing to do, and you can use it for patient response to your treatment. So coming to the first category of ARDS, that is satisfying the initial 3 criteria. First is non-intubated ARDS, which is a new concept, or otherwise you could tell that it is see, we have a PF ratio less than 300 millimeter of mercury, or SF ratio less than or equal to 315, given that the SpO2 is less than 97%. And the patient is on high flow nasal oxygen with a flow of more than 30 liter per minute, or our conventional way of NIV or CPAP with at least 5 centimeter of water. Intubated ARDS, the earlier thing stands our 300, 200, 100 wala cutoff. Along with that, we have incorporated the SF ratio. We have 3 cutoff. Try to learn these values: 315, 235 and 148, equivalent to our 300, 200 and 100. So according to this, we will again reclassify as mild, moderate and severe. One thing to be noted here is that if you are categorizing an intubated ARDS patient, you have to ensure that the patient has a minimum of 5 people. Suppose the patient is on ventilator and the PP score, you cannot classify using this. It has to have a minimum PEEP of 5. And this is adoption of Kigali modification into the guidelines. Modified definition for resource limited setting. Here, simply just based on your SF ratio less than 315, if SpO2 is less than 97, you can categorize that the patient has ARDS. Whether it is mild, moderate or severe is a thing of later consideration. Neither positive end expiratory pressure nor a minimal oxygen flow is required. Even if you have a nasal cannula and the patient is using that to maintain an SF less than 315, you can classify that patient as ARDS. So some additional consideration quickly we will go through. Like I said, USG operator training is very essential. Resource limited setting is defined as the setting where who doesn't have ABG, HFNO, high flow nasal oxygen, non-invasive ventilation or invasive ventilation strategies not routinely available. When to measure your ABG or oximetry, it's not like patient aa raha hai, measure kar raha hai. No. When either the patient is comfortably settled or 30 minutes after any ventilator strategy change, any position change, that is the time when you will measure ABG or oximetry. And oximetry, if you are using the data for diagnosis, it should have adequate waveforms. Pulse oximetry, you should have you should keep in mind that hemoglobin abnormalities if present, pulse oximetry is not reliable, like methemoglobinemia or carboxyhemoglobinemia. In those cases, PF ratio is still the preferred modality. And if there is any altitude, like high altitude, you have to apply the correction formula. Your PF ratio into the pressure by 760. 760 being the normal atmospheric pressure at the sea level. And estimated FiO2 formula, you all know, for every 1 liter we increase the percentage by 3. It is just represented in the form of a formula. And this we have already discussed. Minimum P of 5 is required for all categories of intubated ARDS. So quickly we'll go through some exercises. So a 62-year-old male presented with abdominal sepsis, septic shock and acute hypoxemic respiratory failure. This was his chest X-ray picture and he was mechanically ventilated with an FiO2 of 0.5, PO2 of 75 and PF of 150. Bharat, can you tell which category of new category ARDS does this come under? You have a PF of 150 mechanically ventilated patient. For your reference, I'll show you this. Sir, time. So it will come in intubated ARDS. Now you have to define intubated, non-intubated or resource defined. Then only in intubated you will again reclassify it as mild, moderate or severe. So first you have to say it is an intubated ARDS and then you will say it is a moderate ARDS. Thank you. Please sit. Second case, a 54-year-old female with a history of breast cancer, COVID-19 pneumonia and worsening shortness of breath for the past 6 days. This is a chest X-ray picture. She was on high flow nasal oxygen with 40 liters per minute. You are providing an FiO2 of 80% to maintain an SpO2 of 91. That shows a SF ratio of 1:1:4. Vivek, what category of ARDS will this come under? Non-intubated ARDS? Yes. Non-intubated there is no category. Severe is only in intubated. So it is just a non-intubated ARDS. Non-intubated and ARDS for resource limited setting does not have a categorization. Only intubated ARDS have categorization. So next, 39-year-old female with abdominal sepsis and gram-negative bacteremia in a small under-resourced hospital without blood gas radiography or mechanical ventilation. They had an ultrasound, they did an ultrasound, this is the ultrasound picture. And supplemental oxygen was provided by face mask that was available there. So face mask 15 liter, it will come approximately FiO2 of 6 because 15 to 3, 45, 20 plus 45 approximately 65. So 0.6 will take and SpO2 is 85 in that. So your SF ratio is 142. Amit, what category will this come under? Resource limited area. ARDS in resource limited area. So I hope you guys have understood what is the applicability of the new definition and how it is going to include more patients in ARDS. Yes, please.
I have a doubt regarding that time that you have said that 30 minutes has to be considered before. Is this specific?
No, it's not like you have to wait 30 minutes, but that is the ideal recommended way to do a blood gas or oximetry.
What he's trying to emphasize that if you have changed the FiO2 or some regulatory parameters, you have to wait for at least 30 minutes to see the effect of it. Otherwise, just PR or something.
अच्छा सलीम इसमें रिसोर्स लिमिटेड also they have classified it as mild, moderate, severe.
No, sir.
It's not applicable.
Not applicable, sir. Not applicable for non-intubated or resource limited,
He's
sir.
saying that it is only applicable when the patient is on
Mechanical ventilation. If the patient has a definitive airway, only then we can classify them as mild, moderate or severe. Rest all we will diagnose yes or no. That's it.
HFNC पे तो तूने बोला
HFNC में also there is no this thing, sir. This is also just a diagnostic criteria, sir, non-intubated. This also does not have a severity criteria. This severity criteria is used only if the patient is intubated, sir. We can still use SpO2, but we cannot categorize if the patient is on HFNO.
Just yes or no. That's it.
Yes or no. So, ARDS net protocol, I think every one of you know this very well. Still, I would like to discuss it because it is very important, and how many ever times you revise it, it's not going to be enough. So, this is very important. That's why I'll be revising ARDS net protocol, basic things, how you will adjust everything. So, in which patient do you apply ARDS net? That is basically ARDS patient, but PaO2 less than 300 with bilateral infiltrate and no clinical evidence of left heart dysfunction. That is no, it is not due to cardiac cause. Sir, here I couldn't do that zooming thing. I didn't know how to do that. So this is how you start the patient on ventilator. So first I would like to ask a question. Faisal, what are the different type of body weights you know? Ideal body weight and predicted body weight. So we will not be going into each, but what you should be using in calculating the tidal volume and every setting is predicted body weight. So predicted body weight formula is given here. Please refer to it. After calculating the predicted body weight, you will select a ventilator mode and you will start with a tidal volume of 8 ml per kg of predicted body weight. Once you start that, then you start reducing the tidal volume by 1 ml per kg at an interval less than or equal to 2 until you reach 6. See, while doing this, you have to keep in mind your plateau pressure goals, your oxygenation goals, your PF ratio, all those you will keep in mind. We will come in subsequent slide to each targets, your pH goal, etc. But this is how you approach it. Like you start at 8, then you start reducing VT by 1 ml at less than or equal to 2 hours interval until you reach 6. And initial rate you start approximate to the baseline, but your upper limit being 35. And then you will adjust the respiratory rate and tidal volume to achieve your pH and plateau pressure goals, which we are coming in next. So first of all, what are your oxygenation goals? Your PaO2 should be between 58 to 80, or your SpO2 should be between 88 and 95. 88 is the cutoff, not your 92 to 95, 92 to 96. 88 is enough in case of severe ARDS. So use a minimum PEEP of 5 cm of water. You start with that, then you increase the PEEP FiO2 either based on low PEEP FiO2, higher FiO2 table, or a higher PEEP, lower FiO2 table. Please go through the values. I won't be going through each values, but you can use either table. We will be coming into the evidence of which is better and which is not better in the later slides. But for now, know that both of these tables can be used. So you increment in this table order to achieve your clinical targets. What are your clinical targets? First is your plateau pressure goal. It should be less than or equal to 30 cm of water. If, then what will you do? You will do 4-hourly plateau pressure check. How will you do a plateau pressure check? I hope you all know. We do an inspiratory hold. You can see here there is an inspiratory pause button. You do it for 0.5 seconds. You will get a graph like this, and the ventilator will interpret itself the what is the PEEP light. It will give you the PEEP light values. So this is how you check your PEEP light values. So check PEEP light at least 4 hours and then decide based on what category your PEEP light come. If PEEP light is more than 30 cm of water, it is more than our prescribed normal. So we decrease the VT by 1 ml per kg, keeping in mind that minimal we can keep only until 4 ml per kg. If PEEP light is less than 25 cm and VT is less than 6 ml per kg, even if the patient does not have any problems, you will still increase the VT by 1 ml per kg until either the PEEP light is increased more than 25. Because why do you think a minimum plateau pressure will be required? How will ARDS patient benefit? Prajwal, what do you think? Exactly. So we also don't want to have a very low PEEP. Thank you, please sir. So that's why until PEEP light is more than 25 or until the VT is more than 6 ml per kg. And if PEEP light is less than 30 and breath stacking or dysynchrony occurs, breath stacking means or dysynchrony occurs, you may increase the VT by 1 ml per kg, increment up to 7 to 8. Keeping in mind, you have to keep your PEEP light goals less than or equal to 30. pH goals quickly going through. Alkalosis है तो respiratory rate क्या करना है, कम करना है, बढ़ाना है. अगले alkalosis है तो respiratory rate क्या करना है, acidosis है तो क्या करना है, increase. You will increase the respiratory rate. And alkalosis है तो you will decrease the respiratory rate. Thank you sir. So pH का दो cutoffs दिया है 7.3 and 7.15. 7.15 to 7.3, it's still safe. So what will we do? We'll gradually increase the respiratory rate until the pH is more than 7.3 or the PaCO2 is less than 25. Keeping in mind maximum RR is 25. If the pH is less than 7.15, you don't have to go to an incremental increase. See the keep in 35. If pH still remains less than 7.15, regardless of increasing the respiratory rate to 35, you will increase the VT in 1 ml per kg step until the pH of more than 7.15, and here is the only place where you can exceed the PEEP light limit of 30. And you may also consider giving soda bicarb depending on the clinical condition of the patient and the response that you need from the patient. I ratio का goal एक ही goal है, inspiration should be less than the expiration. Simple as that. Keep it very simple. Inspiration should be less than. Because when you are keeping the rate of 35, imagine how much time you will get for one breath. It will be like 2 seconds, barely. So you have to just keep in mind inspiration should be less than expiration. Now coming to, now you have started the ventilator, all those things. When will you stop this? So there is something called a spontaneous breathing trial. So these are the criteria in which you will consider a spontaneous breathing trial. Like the patient's FiO2 is less than 40% and the PP is less than 8, or the patient's FiO2 is less than 50% and PP is less than 5. Or and, these are all and, not or. Everything should be satisfied. PP and FiO2 values are less than the previous day and patient has acceptable spontaneous breathing. Patient's systolic BP is more than 90 off inotropes and patient is not on any neuromuscular blocking agent. If the patient satisfies all these criteria, you will, and also the patient has been on ventilator for 12 hours. It's not like तुमने चालू कर दिया 6 घंटे के बाद criteria fulfill कर रहा है, you can extubate the patient. No, at least for 12 hours you keep the patient on this. Then you start spontaneous breathing trial for up to 120 minutes. How will you go about it? You place the patient on TPs, or if the patient is tracheostomized on a track collar or on a CPAP pressure support, basically less than or equal to 5 centimeter and pressure support less than or equal to 5. IPAP and EPAP 5. Then you assess for tolerance, that is the patient able to maintain SpO2 more than 90, is the patient able to maintain, or PaO2 more than 60, and the patient's spontaneous VT is more than 4 ml per kg, and the patient respiratory rate is less than 35, and the patient's pH is more than 7.3, and the patient is not in respiratory distress. If you satisfy all these criteria, you consider extubation. If not tolerated, you will go back to pre-weaning state. After 12 hours, you will again try this. So what do you mean by respiratory distress? So they have defined 5 criteria. इसमें 2 होना चाहिए to call the patient having respiratory distress.
When you go for this IPAP, PPAP is 10 and 5, na?
Yeah, that means CPAP of 5 with an extra pressure support of 5. Heart rate more than 120% of the baseline. That is, you put the patient was initially having 80, and you put the patient on spontaneous breathing trial. It became 96 or 97. 96, 80 का 20% होगा 16 heart rate. तो more than 120% of the baseline अगर increase हो रहा है, और accessory muscle use, or abdominal paradox, or diaphoresis, or patient is markedly dyspneic, you will, that is the signs of respiratory distress. And 2, if positive, you will stop the spontaneous breathing trial. So that all about the basic theory which you should be knowing about ARDS, the definition and the ARDS NERD protocol. Now we will be focusing clearly solely on the clinical practice guidelines that will help us on the floor, what things to be done, what things not to be done, and what are the evidences that suggesting for and against it. So this is the European Society of Intensive Care Medicine guidelines on acute respiratory distress syndrome. It came to the recently, and similarly we have an American Thoracic Society document on ARDS. I will be mainly focusing my discussion on ESICM unless it is specifically mentioned that it is ATS, because most of the things are similar. There are some which I have highlighted in red here. Those are the differences of ATS and ESICM. We will be coming to each point, so you don't have to read it here. So first of all, a short idea on what the level of recommendation, what do I mean by. In ESICM, their recommendation they have given based on their literature search, meta-analysis and panel voting. They have said that if they have used the term recommended, that means it has a strong recommendation, that means you should be doing it. If they have used the term suggestion, that means it has a weak recommendation, that means you should consider a case-to-case basis and decide whether the patient will benefit or not. ATS, so clearly they have defined what are their strong and conditional recommendation based on 3 domains, that is patient domain, clinical domain and policymaker domain. We'll just look at the clinical domain. Like strong means it can even be used as a performance indicator. That means you have to do it. If you don't do it, it's a crime. And conditional means you decide based on patient case-to-case basis. So first of all, subphenotype. Shaubik, what do you think subphenotypes are?
So basically, you have told us about 2 phenotypes.
Something based on that. Thank you. So phenotypes are basically an interaction of a genotype and an environment. You get a phenotype. Then a single phenotype can have a various different sub-classification. So why is it important? Let me give an analogy. Like if I ask you to define shock, you will tell me a systolic BP less than 90 mmHg, not responding to fluid therapy, requiring inotropic support. Now I give you like 100 shock patients. I'm telling you all these are shock patients. How will you treat these 100 patients? I want your answer in one single guide management protocol. Will you be able to tell me? Because shock can be hemorrhagic, shock can be distributive, shock can be, it will depend on hypovolemic, it will depend on what type of shock it is. And then further going down, same distributive shock can be because of anaphylaxis, it can be because of Like, so it depends, it can be because of sepsis, it depends. So ARDS is just like that. ARDS is a broad clinical syndrome. It's not like this treatment can be given to ARDS. It is just as dumb as saying this is the treatment guideline for shock. So this is like a paradigm shift. Up to we are trying to define ARDS so that we will pick up all ARDS. Now we know for sure यही है ARDS. Now we are trying to see ARDS का अंदर क्या है. How can we divide it? Is this subgroup benefiting from a particular treatment? Can I change my fluid strategy based on subtype? Can I change my PEEP strategy based on subtype? So that is the importance of subphenotype. So this is just an example. This is not a definition or an all exhaustive list. For you to understand what I mean by subphenotype, you can divide it by etiology like sepsis, trauma, COVID, or you can divide a subphenotype based on timing like early onset ARDS, late onset ARDS. You can. This is a subphenotype which we all know, PF ratio. We divide it. We have a lot of treatment tailored to severe ARDS, treatment tailored to moderate ARDS. So
I'm just interrupting. Is there any integrity strategy difference between different types?
so far, actually, I'll come to some studies, sir. There are multiple studies. They have shown different.
You have to give antimicrobial therapy. You have to give
Yes, sir.
support. You have to give antiviral.
Sir, all these trials showed difference based on subphenotype, sir. I'll come to the discussion in that terms. So, driving pressure ka basis पे physiology, that's it. Or radiographic parameters, like you can have a diffuse attenuation, you can have lobar attenuation, you can have a patchy attenuation, or protein biomarkers. This is a novel thing. Hypoinflammatory and hyperinflammatory subtype they are defining. That is serum soluble receptor for advanced glycation end products, or your non-bone Milliband factor, TNF alpha, or based on new thing that is a gene transcription, transcriptomatics that is still under study. Based on your gene expression, is there any subphenotype? So this is just a pictorial representation. ARDS is a phenotype with all those conditions which you have discussed, and it can have a lot of clinical, they can be divided based on a lot of things like their timing, their etiology, their physiology, their organ failure involvement, their protein biomarkers, their imaging. These which I have given below is currently commonly used subphenotypes that are being used in a lot of studies. This doesn't mean these are the only subphenotype or only classification that is possible. Like trauma and non-trauma, hyperinflammatory and hypoinflammatory, reactive and uninflamed, focal and non-focal based on radiographic pattern as a subphenotype set. So coming here, why is subphenotype important? Like I said, so there was a HARP trial. Yeah, so this HARP trial, it stands for HMG-CoA reductase inhibitors with simvastatin in acute lung injury to reduce pulmonary dysfunction. They tried to see if simvastatin 80 mg per day in 140 patients they gave versus placebo, is there any mortality benefit? So simvastatin therapy, although safe and associated minimal adverse effect, did not improve any clinical outcome. That was their conclusion. But they had a secondary analysis in that told that hyperinflammatory subphenotype seemed to benefit from simvastatin, even though in their study because of data issues and all it was not statistically significant. They have kept an open-ended question that it could be further research to see if simvastatin is beneficial in hyperinflammatory subtype. So this shows one such case where a subphenotype is changing the treatment. Or our live trial. Lung imaging for ventilator settings in ARDS. That is what live trial is. 2019 में हुआ था. So personalized based on lung morphology. So they had a control arm where universally 6 ml per kg tidal volume was given. They had a treatment arm in which they had, if it was a focal ARDS, they gave an 8 ml per kg. They gave low PEEP and prone positioning. And if it was non-focal ARDS, they gave a VT of 6 ml per kg, lung recruitment manual was cited. You don't have to remember this. My point being, they based on the radiological appearance, they devised different ventilator strategies. So, personalization of mechanical ventilation did not decrease mortality in patients with ARDS. But one thing which they realized in their later analysis was that 21% of their patients were misclassified in the radiologic patterns. When they removed that bias in the live trial, they said that a personalized PEEP and prone positioning strategy based on diffuse versus focal radiologic subphenotype achieved a reduction in 90-day mortality. And these other trials which I mentioned here, in alveolar trial and lung safe trial, they had shown that hyperinflammatory subphenotype seemed to benefit from higher PEEP. And in FACT trial, so what is the usual fluid strategy that we adopt for ARDS? We try to go a conservative approach because what? It is a pulmonary edema. You don't want to increase the pulmonary edema by further other etiologies. But in FACT trial, it showed that the hyperinflammatory subphenotype seemed to benefit from a liberal fluid strategy. So this is why I am telling why is subphenotyping important. So tailored treatment modalities and tailored prognostication. like different subphenotype may have different mortality. In some studies it have been shown. So you will be able to prognosticate better. At the same time, it is the scope of further research. It is like a paradigm shift in the area of ARDS. So that's all about subphenotype. Now we'll be coming to recommendations on specific modalities. High flow nasal oxygen. So I'm sure you all have heard about FLORALI trial. High flow nasal oxygen in patient with acute lung injury. 2015 में हुआ था. So acute hypoxemic respiratory failure patient with less than or PF less than 300 without hypercapnia was included in that trial. It was a 3-armed trial: conventional oxygen therapy, HFNO, NIV. So there was a significant difference in favor of high flow nasal oxygen in 90-day mortality. Like intubation percentage was less in HFNO, like it was 38 in HFNO, but it was close to 50 in both NIV and conventional oxygen therapy. Similarly, ventilator free days was also significantly different in HFNO. Ventilator free days was not significantly different, but mortality was different. Ventilator free days was increased in HFNO actually.
Hard to understand the worst performing was NIV.
Yeah, worst performing was NIV in that. That was against what we. Yeah, like the ventilator free days for conventional oxygen therapy was 22, HFNO was 24, and NIV was 19. But even though significant difference in intubation rates was not seen, there was a significant difference in oxygenation. So based on this, they have recommended that in non-mechanically ventilated patient receiving high flow nasal oxygen as compared to conventional oxygen therapy to reduce risk of intubation, but they are unable to make any recommendation on mortality. I have given in bracket what is the level of evidence and grade of recommendation. HFNO versus NIV, based on, and all these recommendations are not based on any single study. It is based on the meta-analysis of the pooled data. So you won't be able to find this recommendation in any papers. It's based on multiple studies. They have aggregated the data, done a meta-analysis, then had a panel discussion based on the results of meta-analysis, and finally made this recommendation. So that's why at times you might see like the recommendation is conflicting with the study just described, but that is because it is after a meta-analysis. So they are unable to make a recommendation for or against the use of HFNO as compared to CPAP or NIV to reduce both intubation and mortality. So what about continuous positive airway pressure and non-invasive ventilation, CPAP and so here also they have mentioned they are unable to make CPAP versus conventional oxygen therapy. They are like for or against. We are not telling you use it, we are not telling you don't use it. Based on clinical gesture basically. So neither intubation nor mortality is affected by NIV versus conventional oxygen therapy. And CPAP versus BiPAP also, they are unable to make any recommendation. So all this means based on the clinical situation, clinical gesture of the patient, of the physician, you will decide what to do. Low tidal volume ventilation. This is an age-old recommendation. Everyone knows we have the baby lung concept. We have to give low tidal volume, 4 to 8 ml compared to larger tidal volume to reduce mortality in patient with ARDS. Interestingly, the primary analysis of their meta-analysis did not show any mortality difference between low tidal volume and high tidal volume strategies. Like the data here is, they had a relative risk of 0.96 with a confidence interval that is crossing the midline, 0.72 to 1.28. P-value of effect being 0.76. But they have justified it by saying, considering the extreme strong physiological rationale underpinning the use of low tidal volume based on animal and human studies, we still keep this recommendation. So it is still a recommendation even though it is not supported by evidence. It is based on expert opinions. So PEEP and recruitment maneuvers. So first we will go to PEEP. Alveoli trial. So alveolar trial was conducted in 2004. Low PEEP versus high PEEP. Low PEEP had an average PEEP of 8.3. High PEEP had an average PEEP of 13.2. Primary endpoint was death. Clinical outcomes are similar, whether higher or lower PEEP was used. This was their conclusion. Laus trial, which came in 2008. So in Laus trial, lung open ventilation strategy, that is Laus. So in 2008, 983 patients were included in this. They had a control arm with a normal VT of 6 ml, P-plat less than 30, and they had an experimental arm in which 6 ml per kg, P-plat less than 40. The other arm had P-plat less than 30. Here they kept a higher PEEP in an experimental arm. 40 तक रख के देखा था कि if do increasing the PEEP reduce the mortality by increasing the lung recruitment. So they showed that no significant difference in all-cause hospital mortality or barotrauma compared with an established low tidal volume ventilation. And coming finally to Express trial, which came in 2008. Similarly, alveolar recruitment, a strategy for PEEP aimed at increasing alveolar recruitment, did not show any significantly improved mortality. But it did improve lung function, like reduce the duration of mechanical ventilation and the duration of organ failure. That was shown in express trial. Like same, they have divided into two arms. Minimal distension, that is moderate PEEP, they had used 5 to 9 centimeter of water, and increased recruitment, that is PEEP to reach a P flat of 28 to 30 regardless of your SF ratio goals or PF ratio goal. They had kept that I will maintain the target P flat of 28 to 30 so that I have the maximum recruitment of alveoli during the ventilation. So even though there was no significant difference in the mortality, it did improve lung function and reduce the duration of mechanical ventilation organ failure. So these are the trials, main trials. Now coming to recommendation by ESICM. So based on their meta-analysis, they again concluded that we are unable to make a recommendation for or against high versus low PEEP. But let us see what the American Thoracic Society says. They had actually suggested using a higher PEEP without lung recruitment maneuvers. They have specifically mentioned to not use lung recruitment maneuvers rather than a lower PEEP. But the thing to be noted here is, here they have defined a subpopulation, moderate to severe ARDS. Here it was ARDS. So the justification that is mentioned in the ATS paper itself is that we are recommending to tailor to a subpopulation with a more narrower intervention, that is higher PEEP without lung recruitment maneuvers is being recommended rather than just a higher PEEP. And rather than just mentioning ARDS, they have subcategorized it into just a patient with moderate to severe ARDS. So this is a conditional recommendation. So in the end again, higher PEEP or lower PEEP as per ESICM we have no recommendation, but this recommends higher PEEP. So coming to something interesting, like there is a trial called EPVENT trial. In this trial what they did was, they had a PEEP strategy guided by something very interesting. Like they calculated a transpulmonary pressure. How did they calculate this transpulmonary pressure? Alveolar pressure minus the pleural pressure. So how did they calculate the pleural pressure? They inserted a esophageal probe. Esophageal pressure was taken as the pleural pressure. They calculated transpulmonary pressure, and then the PEEP was titrated according to the transpulmonary pressure. They try to see if respiratory mechanics ka basis pe, if we are making any PEEP titration or anything, does it change mortality? No significant difference in death or no significant difference in ventilator free days. EPVENT ka or EPVENT 2 trial bhi hai, but this. So they are unable to make any respiratory mechanics based PEEP titration also. They are unable to make any recommendation. So now coming to lung recruitment maneuvers. I think you all know what are lung recruitment maneuvers, but quickly going through. We have multiple ways in which we try to recruit. This is the concept. Multiple ways in which you try to recruit the collapsed alveoli, the atelectated area. You try to recruit that. Either by a sustained inflation. You keep a very high PEEP like 30, 40, 50, 60. In multiple studies even 50 it has been used. For 30 to 40 seconds, some studies 1 minute, some studies 2 minutes. Or there is incremental PEEP titration. You slowly start from trial, you increase it while monitoring for response. Or you start with a high PEEP and driving pressure, or then you have a staircase phenomena. You increase, then you decrease. You increase, then you decrease. You increase by 10, decrease by, you will see where you get the least driving pressure. You will consider that where you get the least driving pressure is when the lung is having maximum compliance. So usme you will set the PEEP. But these are the recruitment maneuvers, and recruitment maneuvers can be broadly classified into a prolonged or a brief based on you give an airway pressure more than or equal to 35 centimeter water. If maintained for at least 1 minute, you call it a prolonged high pressure recruitment maneuver, and if you will keep it less than 1 minute, you call it a brief high pressure recruitment maneuver. So coming to the ART trial. So ART trial, alveolar recruitment for ARDS patients. So they compared 1010 patients, lung recruitment maneuver arm versus a low PEEP arm. 28-day mortality. In lung recruitment maneuver arm, the mortality was 55.3%, and in low PEEP arm, the mortality was 49.3%, with a hazard ratio of 1.2, and which was significant. So this showed that in patient with moderate to severe ARDS, a lung recruitment strategy increased the 28 days all-cause mortality. And PHAR-LAP trial, this is also similarly recruitment ventilation strategies. In this also did not reduce the duration of ventilation free days and increased cardiovascular adverse events with the lung recruitment maneuvers. But there was lower use of hypoxemic adjuvant therapies. So they have recommended against the use of prolonged high pressure recruitment maneuvers to reduce mortality in patients with the ARDS. Similarly, they have recommended against, suggested against. This is a recommendation because they have strong recommendation and moderate level of evidence. This is a weak recommendation, so they have suggested against the use of brief high pressure recruitment maneuvers to reduce mortality in patients with ARDS. Prone positioning. So this is just the physiology mechanism by which prone positioning affects. Once you keep the patient prone, there is less pressure from the heart on the lungs. There is more homogenization of the alveolar size and less alveolar strain, ventral alveolar strain. While keeping in prone position, you have to keep in mind these pressure points. This proper nursing care should be given because we are recommending a prone position, prolonged prone position for more than 16 hours. So you should keep in mind all these pressure points to be kept in mind before keeping on prone position. This is the major trial, PROSIVA trial. In this more than 16 hours prone positioning was done and they showed prolonged prone position significantly decreased the 28 and 90 day mortality. So they have recommended the use of prone position in this subcategory, that is PaO2 and FiO2 less than 150 with a PEEP more than 5 cm of water despite optimization of ventilator strategy, and this will reduce mortality. Timing of prone positioning also they have said as soon as possible, basically after intubation and a period of stabilization and optimization. After optimization, the patient satisfies these criteria, you start giving the patient prone positioning. There is a concept of awake prone positioning. That is, if you are non-intubated COVID ARDS patient and all, you keep the HFNO, you keep them on prone position. So they have a suggestion that in COVID-19 related ARDS patient, there is role of awake prone positioning, but they are unable to make any recommendation in non-COVID or other causes of ARDS. Neuromuscular blocking agents. This is also have conflicting recommendation by ATS and ESICM. So first of all, some general consideration. We don't have any proven optimal agent. Cisatracurium was most frequently used in trials. So ATS recommend that it can be, not recommends, they just mentions that cisatracurium may be considered. So since that is mentioned, I just kept the dosing of cisatracurium. Please go through it. So first 2010 we had the Accurasis trial. So Accurasis trial showed that in patient with severe ARDS, early administration of continuous neuromuscular agent improved the adjusted 90-day mortality and increased the time of ventilator without any neuromuscular paralysis. But then came the ROSE trial. ROSE trial in 2019, no significant difference in 90-day mortality was shown with 48-hour infusion versus usual care, and more adverse cardiovascular events was found in the atracurium arm. So what? Based on their meta-analysis, they have recommended, ESICM have recommended against the use of routine continuous infusion of NMDA to reduce mortality in patient with moderate to severe ARDS. But what does the ATS say? ATS says that we suggest using neuromuscular blockade in patient with early severe ARDS. Here also they have mentioned that, here also we have mentioned the specific subpopulation, that is they have defined that it should be early, that is less than 48 hours since diagnosis, and it should be severe, that is PF less than 100. In that they have a conditional recommendation with low certainty of evidence that neuromuscular blocking can be given. The conflicting data can also be justified by the difference in studies that have been included in the meta-analysis that have been used by the respective committees that used for guideline development. Coming to, we are almost nearing our end of presentation, don't sleep. Extracorporeal life support. So, Kirtan, what are the type of extracorporeal life support you know?
ECMO.
Sir,
ECMO.
So ECMO का type से we have VV ECMO and VA ECMO. So ECMO क्या करता है? ECMO helps in oxygenation. So there is a different type of extracorporeal life support also. Does anyone know about it? Extracorporeal carbon dioxide removal. There is also one such type. So we'll be mentioning about both. What is the recommendation about extracorporeal oxygenation? At the same time, what are the recommendation about extracorporeal carbon dioxide removal? So we have two trials I'll be discussing here for extracorporeal ECMO. One is CSER trial. So after their analysis, they concluded that if the patient has severe but potentially reversible cause of ARDS, Murray score means our lung injury score, which we discussed in our third slide. Yaad hai na? Yeah. So Murray score exceeds 3, who have pH of less than 7.2. On conventional management, they are telling if you have ECMO, start ECMO. If you don't have ECMO, transfer the patient to ECMO. Eolia trial, they said that early use of ECMO. This is not a, they have defined some predefined inclusion criteria. वो criteria fulfill कर रहा तो regardless of the patient needed it or patient was maintaining, they had early started ECMO. Early use of ECMO did not significantly improve mortality at 60 days. Now pooling the data from both the trials and the meta-analysis. Before going into the recommendation, here I am mentioning this because this is mentioned in the recommendation. Like this has to be used if you are considering ECMO. So they have mentioned, this was the inclusion criteria of Eolia trial. That is, you have severe ARDS, patient was intubated less than 7 days, and despite optimal mechanical ventilation strategies and appropriate rescue therapies, patient either had severe hypoxemia or persistent respiratory acidosis. Hypoxemia definitions they have given here, and respiratory acidosis definition also I have given here. So based on this is the ESICM recommendation, that is, patient with severe ARDS as defined by Eolia trial eligibility criteria should be treated with ECMO in an ECMO center which meets defined organizational standard, and adhering to management strategy as per the trial. So now this is a very interesting thing. Like some people try to see that हम तो lung protection करके जा रहे हैं. What if I give like 3 ml per kg, 2 ml per kg भी दे सकता है? What is the problem if I am oxygenating? Suppose I am able to provide adequate FiO2, I am able to maintain adequate PaO2. Only problem we'll have with the low ventilation is that PCO2 retention. So they thought that we'll reduce so much time volume so that we'll prevent so much lung injury, and then we'll remove that extra accumulated carbon dioxide by extracorporeal carbon dioxide removal. Simple difference between ECMO and ECO2R is ECMO में your flow rate should be very high, 3 to 7 liter. ECO2 में you, because carbon dioxide extraction के लिए बहुत कम blood चाहिए, तो around 450 ml to 1 liter होगा your flow rate in extracorporeal carbon dioxide removal. So they tried very low tried rolling strategies with extracorporeal carbon dioxide removal. In this they concluded that it has potential to further reduce villi, but whether this improves survival remains to be determined, which a second REST trial came. REST trial mein they showed that such a strategy did not reduce 90-day mortality, and the extracorporeal carbon dioxide removal is associated with just the complication, just like your ECMO, all the bleeding manifestation, a lot of things can happen. So that's why against the use of extracorporeal carbon dioxide removal for the treatment of ARDS to prevent mortality outside of randomized control trial. This they have kept so that further trials can be done to further define and better data, granular data can be obtained regarding this modality. Last topic, second last topic, corticosteroids. In ESICM they have no recommendation mentioned about corticosteroids, but the reason being, in the initial description sir, they have explained that the scope of this clinical practice guidelines was limited to ventilator modalities and neuromuscular blocking agents. No other pharmacotherapies will be discussed, so that's why it is not there. Let's see what the FICM 2018 ARDS what they tell is that corticosteroid in established ARDS should be a subject of suitably powered multicenter RCT. So us samay bhi they did not have any recommendation on corticosteroids, but we have recommendation from ATS. ATS suggests the use of corticosteroids, suggests with patient for patient with ARDS. So this I think Mayuri had also discussed in her What's New in EM. So just it reduces mortality. In the meta-analysis they are shown to reduce mechanical ventilation, reduce the length of hospital stay, with safety concerns being increased risk of hyperglycemia and upper GI bleeding. And corticosteroid precaution to be taken is that there is risk of harm when you start it more than 14 days, and adverse, this is very relevant to our population actually, that they are telling higher risk of adverse event in patient with immunosuppressed metabolic syndrome, non or increased risk of fungal parasitic or mycobacterial infection. If they are being called the capital of mycobacterium, we should be considerate whether to start corticosteroids in our patient or not. So optimal regimen of corticosteroid is unknown. If some tailored predefined doses condition is present, suppose you know Cape Cod trial have defined the severe community acute pneumonia में कितना देना है. अगर ऐसे predefined dose पहले से है तो you can use dose regimen. Otherwise they are telling any dosing regimen that is usually used in these trials can be used. And if it is rapidly improving patient, they are telling you can discontinue at the time of extubation. So these are some corticosteroid regimens, not any recommendations or anything, just for your information. Please go through it. But they have said avoid glucocorticoids in patients in late disease course, we have told already, more than 14 days, and patient with influenza infection, because independently influenza में corticosteroid as an adjuvant therapy has been shown to increase mortality. Last topic, fluid management. We have already discussed in between, but simply conservative fluid strategy rather than severe liberal fluid strategy, provided that you prevent hypotension and organ hypoperfusion, and that is because there is increased risk of pulmonary edema. Conservative fluid strategy have shown to improve oxygenation, improve the lung injury score, improve the ventilator and ICU free days, but no mortality benefit is present. So again, like I said, there was a subphenotype that had benefited from liberal fluid strategy. Yeah, so it is plus or minus. Inhaled I won't be discussing in detail, just kept it for your reference later. Basically it can be tried as a rescue therapy, but no mortality benefit. It can be an age old thing, no mortality benefit, so won't be discussing. Coming to the conclusion, our take home points will be, there is a new category called non-intubated ARDS. There is an ARDS in resource limited setting. We have incorporated ultrasound into ARDS diagnosis. There is a new domain of subtyping of ARDS. We recommend HFNO for non-intubated ARDS. Still recommend low VT strategy. High versus low, we have conflicting data, depends. No recruitment maneuvers should be used. No routine use of neuromuscular blocking agents. Prone positioning if the patient is intubated. In intubated patients, awake prone positioning in non-intubated patients, specifically in the subcategory of COVID-19. VV ECMO in selected population, and corticosteroids depending on our severity and everything. I have just included their summaries here. Please go through it. We have discussed all these things. These are my references. Thank you. And any questions? Any questions?
We have clarified everything.
Comparison between NIV and HFNO in subtype of immunosuppressed patients.
Actually, COVID-19 immunosuppressed, maybe they have just the same recommendation. That's what, no recommendation. Whatever is in the general ARDS, same thing they have recommended.
Plurality of the specific subgroup in which they say.
That's why I told you, specific trials have shown benefit in a lot of ways. But the meta-analysis, pooling the data from all the trials have failed to show any benefits. So that's why they haven't concluded. And if for exam and all you want to study, don't go through my 100 slides. This is the summary given by ESICM itself. All the recommendations they have beautifully summarized here, and the clinical question which led to the recommendation have also been summarized here. And these are the justification provided by the ATS for their difference in these two strategies as per ESICM, and just some small differences between ECMO and ECCO2R. Please go through it. Thank you.
Excellent presentation by Salim, and almost he has covered everything, especially for first semester and second semester residents. You see the amount of effort he has put in making this presentation, and he completed this in 1 hour. So starting from somewhere around 1967-63, when the concept of ARDS came till 2024, when we have some recent modifications, he has covered everything. The topic was important because there have been many modifications practically, and followed by the 2024 ESIC recommendations. On a parallel track, he has also covered what the ATS is saying. Mostly we are following the ESIC guidelines, but ATS also has some say regarding, and at one or two conflicts, ATS is suggesting, for example, the use of steroids. ATS is suggesting
higher.
So he has discussed, I think, more than 20 trials during his presentation, and what Vignesh was asking that, for example, say Florali is saying something, or some other trial is saying something, but the recommendations are based on systematic reviews and meta-analysis, and that goes for a strong recommendation or a class A or class 1 evidence. So that's what ESIC or the ATS is doing. So again, excellent presentation from you. What we expect is at least you should be thorough with the ARDS net protocol based on the plateau pressure, how you can titrate your ventilator settings. So I'm saying this because the next, I think, few classes we can have a practical session on that. We'll give you a scenario and we have to solve that. What will be your ventilator settings, what will be your parameters based on this scenario. So please don't forget the ARDS net and the other parameters which he has discussed. You have to go home and just thorough it. That is important, because if you are not applying it on floor, it's not of much use. Because emergency में patient may be there with you for around 24 to 48 hours. Prone positioning, other things may be difficult in emergency settings, but definitely you can help with the ventilator settings, especially in the early stages when the patient is with you. Again, thank you, Salim, for this excellent.
थोड़ा 5 minutes break दे देना थोड़ा
So one more technology is electrical impedance tomography we saw it in a workshop. So there is 16 electrodes that on the G-shape ventilated. So gives colors, it just generates colors and the areas are divided into 4 zones, 1, 2, M, or you can divide it into quadrants, 1, 2, 10, 1, 2, 3. And on basis of color coding, it tells you how much part of your lung is ventilated, whether you can get any recruitment or by increasing the peak you can increase the ventilation or not. So we just saw that we see the ventilation or not.
But already he has discussed an English we are setting up transesophageal and then it found finally benefit.
So I missed particular steroid in the RDS.
Yes.
What was the last one?
Fluids.
Fluid restriction is
That's yes, it has no recommendation. The persons have been also discussed that further research has to be done. But ATS has
conditional approval is there.
ATS has a conditional approach.
So कितना वैसे कितना आपके वॉइस इतनी कैलकुलेटिंग है लाउड कैलकुलेटिंग चला सर बड़ा
हाँ
उसको नहीं लगा क्या
Today I'll be going to present on approach to cardiogenic shock. I am Dr. Shobik, third term emergency medicine, and my guide is Dr. Jamshed sir, additional professor. Sir, finalized it last
The
night.
slides here, another beautiful thing about Salif's presentation is whatever suggestion I had given him, he incorporated those suggestions in his presentation. When we met in person, उसने अपने slides दिखाए. Few days before his presentation, whatever inputs I gave him, एक जगह I had asked him to put some animation. He was not able to do that, which he apologized for. But apart from that, इसने बहुत सारे modifications किए. Using those modifications, he saved almost 15 minutes of his presentation.
अभी भेजना देखो
Because he was going to discuss ATS separately. That would have taken another 15 minutes, and it becomes difficult for the audience to correlate what ESIC have told, what ATS is saying. Parallel डाल देने से now it's going side by side. So the audience has, the decision making is more clear. So again, that was a good thing, sir.
So I'll be running through these points: definition and classification, epidemiology, etiology, a little bit about RV cardiogenic shock, and etiological management of cardiogenic shock. I'll be covering some specific topics itself. Just as you have seen the previous presentation, ARDS is a very organized, I feel, very organized approach is there. Cardiogenic shock is exactly the opposite thing. So we do not have recommendations, we do not have any organized way to approach, but we will be trying to cover as much as possible. So one disclaimer over here is that my presentation will be slightly in continuation with the presentation that has happened, that was taken before by Vishnu sir. So I am not going to cover each and every aspect what sir has covered, especially the fluid assessment part and all those things. I'll be covering some newer topics in this. Vasopressor and inotropes, a little bit detailed discussion about what we actually use in the ED and can we make better choices in them. Temporary mechanical circulation support, again not available in India, but we should know, since when we go to US or outside India, this is a big discussion, as this is generating a lot of income for the hospitals over there. But again, is there any evidence, and why is it not in India, and are we actually satisfied or are we happy with not having it in India? And yeah, finally the conclusion.
So this is just a broad definition. What is cardiogenic shock? Defined as a complex heterogeneous multifactorial syndrome in which a cardiac disorder results in insufficient cardiac output culminating in an end organ hypoperfusion. So the European Society of Cardiology defines cardiogenic shock as SBP less than 90 mmHg with adequate blood volume and clinical or laboratory signs of hypoperfusion. Clinical signs of hypoperfusion include cold extremities, oliguria, altered mentation, dizziness, and lab signs include metabolic acidosis, increase in blood lactates, and increase in blood creatinine. The American Heart Association uses the other two, that is the IABP. These are basically taken from two landmark trials in cardiogenic shock, that is the SHOCK trial and the IABP SHOCK 2 trial. So the IABP SHOCK 2 trial defines it as systolic blood pressure less than 90 mmHg for at least 30 minutes or a need for catecholamine, that is vasopressor or inotrope, in order to achieve an SBP of more than 90 mmHg with signs of pulmonary congestion with signs of hypoperfusion. Which include altered mental status, cold skin, urine output less than 30 ml per hour, lactates more than 2. The SHOCK trial defines it as SBP less than 90 mmHg for at least 30 minutes or need for support in order to achieve an SBP more than 90 mmHg. With hypoperfusion signs which include cold skin and urine output less than 30 ml per hour, and a hemodynamic criteria has been added to it, which is cardiac index. Cardiac index, as we define it, as cardiac output by the body surface area, which is less than 2.2 liter per minute per meter square, and a pulmonary capillary wedge pressure more than 15. Why is it important? It means that they suggest using a pulmonary catheter for all patients who are basically in cardiogenic shock, something which we are not doing over here. So this is a roadmap for evaluation and management of cardiogenic shock given by the Annals of Intensive Care. This paper was published in 2023. So it says it gives a mnemonic known as suspect CS, which is signs and symptoms, urine output, sustained hypotension, perfusion, ECG, echocardiogram, congestion, and triaging accordingly, like where the patient should be managed. This thing should be done within the first 30 minutes when the patient arrives from in our trial setup. In the next 60 to 90 minutes, the patient should receive initial management as well as appropriate triaging should be done. Whether if it's a cardiogenic shock secondary to a myocardial infarction, the patient should be in the cardiac cath lab. For other cases, the patient should be in the cardiac care unit, and higher level of care obviously if you do not have that kind of facility available over here. And 6 hours, 12 and 24 hours, the patient should be stabilized, optimized to achieve adequate decongestion, metabolic and hemodynamic targets, personalized intervention depending on what cause of cardiogenic shock it is, and an assessment of an exit strategy if like cardiac transplantation and ventricular assist device if you have, again not something which is relevant in India, and palliative care engagement for those patients who are experiencing something known as refractory shock with limited therapeutic options. So the suspect CS, signs and symptoms which include altered mental status, confusion, chest pain, low pressure, low pulse pressure, cold clammy extremities, crackles, rales, orthopnea, PND, lower extremity edema, etc. Urine output defined as oliguria or anuria less than 30 ml per hour. Sustained hypotension, that we have already discussed, an SBP less than 90 mmHg or a MAP less than 65 for more than 30 minutes, or a 30 mmHg decrease from the baseline, or the need for pharmacological or mechanical support to maintain an SBP more than 90 mmHg. Perfusion defined as lactate more than 2, increase in the liver enzyme, increase in creatinine, and metabolic acidosis with pH less than 7.2. ECG echocardiogram to know what is the cause of the cardiogenic shock, which includes a STEMI or an evidence of LV or an RV dilatation causing an acute right heart failure or valvular pathology. Congestion, that is whether the failure is predominantly a left ventricular failure or a right ventricular failure or a biventricular failure, and triage accordingly and decide where to transfer the patient to. That is the end of the 60 minutes. So SHARC classification. So this is SHARC stands for Shock Association of Shock Research Consortium, Shock Academy of Research Consortium. So this is the latest classification on cardiogenic shock, and it is accepted by both the European Society of Cardiology as well as the American Heart Association. So it defines, it classifies mainly into 4 types, that is acute myocardial infarction related cardiogenic shock, which is further divided into STEMI, NSTEMI, heart failure related cardiogenic shock, which is primarily a left ventricular or right ventricular failure. This can be further divided into de novo heart failure, that is when the patient has presented directly for the first time with a heart failure cardiogenic shock, and or an acute on chronic kind of presentation. Secondary cardiogenic shock, when it is secondary to either an arrhythmia or a pericardial disease or a valvular heart disease, which needs to be further subclassified, and a post cardiotomy cardiogenic shock in the setting of a cardiac surgery. Some additional modifiers are included over there, which must be included in your diagnosis. Ideally, that is whether it is predominantly a left ventricular failure or a right ventricular failure or a biventricular failure, whether the patient has a post cardiac arrest status, or some specific things which do not fit into this classification are myocarditis, cardiomyopathy, amyloidosis, cardiac amyloidosis, or peripartum cardiomyopathy, and a mixed shock syndrome. So this is the severity classification that we use. It is given by the Society for Cardiovascular Angiography and Interventions. So this was published in 2019, and it divides it as A, B, C, D, E, where A is having the lowest mortality and E having the highest mortality. So A is at-risk patient, any patient who has a large acute myocardial infarction or an acute on chronic heart failure, presently not in cardiogenic shock. This is a patient who is at risk. Next is B, beginning, where there are signs of relative hypotension or tachycardia, but there is no obvious hypoperfusion. That is, the lactates are normal, urine output is normal. Classic cardiogenic shock is the one that we tries the patient to read. Patient presenting with hypoperfusion requiring intervention beyond volume resuscitation. That is either an ionotrope or a pressor support or a mechanical support. Deteriorating is same as the classic but worsening status. And extremis is the one who's in a CPR or undergoing an ECMO presently. So why is this important? Because the mortality is defined accordingly. So when someone is at A, 0.6 in hospital mortality, and the long term mortality is around 24%, and it keeps on climbing 2.7, 21.5, and when the patient is in E, 90.6% in hospital mortality, and long term mortality is also similarly increasing. So causes of cardiogenic shock can be broadly classified as acute myocardial infarction related, where it is either because of the pump failure that there is low cardiac output, or mechanical complications secondary to an acute MI, like an acute mitral regurgitation, a VSR, ventricular septal rupture, or a free wall rupture or a cardiac tamponade, and a right ventricular MI. Based on cardiomyopathies, that is a valvular heart disease, and ischemic cardiomyopathy, a restrictive infiltrative cardiomyopathy, a dilated cardiomyopathy, and idiopathic causes. Endocrine causes related to basically secondary to bradyarrhythmias, tachyarrhythmias, peripartum cardiomyopathy, secondary to medications. Like here we see a lot of subset of cancer patients who are on some chemotherapy undergoing heart failure secondary to the chemotherapy, cardiotoxic chemotherapy. Acute myocarditis, relatively young patients presenting with secondary to viral, toxic, infectious, or septic myocarditis, and post-traumatic causes of cardiogenic shock. So the sharp definition of cardiogenic shock is defined again, as we have discussed, more or less similar, less than 90 mmHg for more than 30 minutes with need of vasopressor, inotropes, or mechanical circulatory support to maintain adequate BP alongside evidence of systemic hypoperfusion. They are further gone and divided into 3 types: normotensive cardiogenic shock, hypotensive cardiogenic shock, and an RV cardiogenic shock. So around 5.2% patients, 5.2% of the patients who were registered in the shock trial have had a normotensive cardiogenic shock. However, the cardiac index over there was less than 2.2, and they had a high systemic vascular resistance. That's why normotensive and cardiogenic. RV cardiogenic shock included almost 5.3% of the patients. They had a normal cardiac index, normal pulmonary capillary wedge pressure, and a raised right atrial pressure. We'll discuss that in the further slides. And a hypotensive frank cardiogenic shock, that is around 90% of the patient, 89% of the patients. So we'll discuss quickly about the etiologies of an RV cardiogenic shock. So first is chronic pulmonary hypertension. We know group 1. Anyone? Prajwal, can you please tell the types of pulmonary hypertension? Groups. One is idiopathic pulmonary artery hypertension. Two is secondary left ventricular failure.
That is
Chronic hypertension. Fourth is chronic thromboembolic, and fifth is miscellaneous. So all those groups of patients, and second is patients presenting with acute pulmonary hypertension. The examples are over there. The massive pulmonary embolism, a fat embolism, or an air embolism. 50% of the patients. Lung diseases, ARDS, pneumonia, sickle chest syndrome again come with acute pulmonary hypertension. And acute LV failure, that is acute aortic regurgitation, acute mitral regurgitation, which can present as a right ventricular failure. Non-adherence to pulmonary hypertension medications, conditions with excessive preload like a tricuspid regurgitation, pulmonary regurgitation, VSD. It has also been suggested that septic cardiomyopathy, because of the cytokine storm, it can lead to pulmonary vasoconstriction and cause a right heart failure. And RV myocardial infarction, as we know, and rare causes like myocarditis, arrhythmogenic right ventricular dysplasia, sarcoidosis, etc. So the pathophysiology of RV cardiogenic shock, why is it important? So basically this is a vicious cycle. There are multiple vicious cycles inside while a patient with RV failure continues to worsen. So basically in a patient of acute RV failure, the RV will, since cannot undergo as much hypertrophy as the left ventricle, it will give away, and the interventricular septum will shift towards the opposite side, something known as the reverse Bernheim effect, which will cause a decreased cardiac output, leading to hypotension. Now hypotension normally, like we do in our ED setup, we start the patient on noradrenaline, we will start the patient on alpha agonist medications, which will ultimately cause pulmonary vasoconstriction and then further worsen the RV failure. That is basically the left side of the other graph as well. But it also suggests that chronic RV failure patient will go on to develop a functional TR and cause a right atrial enlargement that will lead to atrial fibrillation, and that again will cause a low cardiac output. So basically multiple circles inside, multiple vicious circles inside once the pathophysiology starts. So breaking the chain at some point is very important in RV cardiogenic shock.
There is a paradigm shift nowadays as far as I'm understanding the heart failure and cardiac shock is concerned. Initially, multiple studies they damaged specifically the right ventricle to see the effects in animal studies. Initially, we started with 19 and then 1978. Multiple studies are there, and they concluded that there is hardly any difference as far as the ejection fraction of the patient is concerned. So it is not that important. Then there is you understand the Fontan procedure where actually we bypass the right ventricle and directly it is connected to the pulmonary artery. Again, the result was that ejection fraction was not changing much with the bad effect of the patient's output. Later on they realized that we can use the filtration and finally actually use the modality. That is why they started again to rethink that this RV, which is also very important. And unfortunately, there is RV damage is there. It is very difficult to manage, number one. And overall, the prognosis of the RV failure is much more worse than the LV failure.
So again, what Sir also meant, we need to have an RV-centric management. If we know that we are dealing with an RV failure, the management approach changes a lot. This is known as the RV-centric resuscitation strategy. So yeah, so I'll be mainly covering about RV cardiogenic shock, and about the left ventricle I'll be covering mainly about the valvular heart diseases, the normal cardiomyopathy and all we are managing I think pretty well. We just there's nothing much to do over there apart from temporary mechanical circulation.
There is a review article published in India 2023. Somewhere in March or April 2020. It's a very good review article. Just go and read.
So how to pick up an RV failure? So an ECG showing an RVBP, RV strain pattern, RVH or right atrial enlargement, and echocardiography. Usually the IVC will be dilated. The IVC will always be chronically dilated in these cases. So actually being able to find out whether the patient is in the volume overload or not will slightly be challenging, and we'll be discussing how do we do that. If the patient has chronic RVH, like less than 5 mm is mild, 5 to 10 moderate, and more than 10 mm severe. RV septal assessment. So the RVH, the grading of RVH based on RV dysfunction. So less than 5 mm, 5 to 10 mm, and more than 10 mm is like severe dysfunction. So RV septal assessment, where we use the D sign. The D sign in diastole, they say it correlates with volume overload, and the D sign in systole correlates with pressure overload. So basically, a patient with having a D configuration in diastole is a volume overload. That means it is an acute right heart failure, and pressure overload more likely something to be of a chronic etiology. The tricuspid annular plane systolic excursion. This is described as one of the best indicator for RV systolic function at the bedside. So it's pretty simple. Get a 4-chamber view, find the tricuspid wall, and it's a chronic pulmonary embolism will have a systole. Grading for the TAPSE, normal TAPSE more than 17 mm, and mild again 10 to 17 mm, moderate 5 to 10 mm, and severe will be less than 5 mm. The TR jet, getting a TR jet 4-chamber view, and just putting the Doppler over there, that will give you a TR jet. TR jet more than 3.4 meters per second suggests pulmonary hypertension is very highly likely, and you get a Doppler for that. So that gives you the pulmonary artery systolic pressure, which is the central venous pressure plus the right ventricular systolic pressure. Through the graph, you will get the right ventricular systolic pressure when you trace the graph. Values more than 40 mmHg again are suggestive of pulmonary artery hypertension. Something known as the pulmonary acceleration time. You get a short axis view, and at the aortic level.
Concept of TAPSE with ASP ratio. This is very important to know that what is the TAPSE with ASP ratio. Normally it should be more than 0.38. If it is less than that, there is a only failure. If it is less than, I think, 0.8, 0.18, there is high mortality. So just go and read about TAPSE with ASP ratio.
So we get the pulmonary trunk view and put a pulse wave Doppler over there. So and we calculate it from the start of the pulmonary flow, that is the onset of the pulmonary flow, to the peak velocity. Normally it is more than 130 milliseconds, and if the values are less than 100 milliseconds, they suggest again pulmonary hypertension. 60/60 sign, something you might have heard about for an acute pulmonary embolism. The RV systolic pressure less than 60 and a pulmonary acceleration time less than 60. So basically it suggests acute because the RV has not compensated yet. The specificity and sensitivity is around 25%, specificity over literature is around 90 to 100%. This is using the common femoral vein Doppler for assessment of RV, something which we don't do over here. So defines as A, B, C, D, E, A, B, C, D. B is the normal thing, that is you can see a continuous flow with some respiratory variation. When you do not see a respiratory variation, you should rule out a thrombus over there, proximal thrombus over there. So the respiratory variation should be there. That is pretty much normal. If the common femoral vein actually collapses during inspiration, then that suggests hypovolemia. But that you can always rule out with the IVC as well. You can see an IVC and you can confirm that way. So moving to the C part, that is when it is increased, you see reverse flow starting. The small thing going upward is known as the A wave. If it is less than 5 centimeter, they say that it is 5 mm. Then they say that it is mild dysfunction, and when it is more than 5, it is more than it's a severe dysfunction of the RV. Common femoral. Yeah, management. The alternate for this is the Vexus protocol, something which I won't be discussing today. The Vexus protocol is slightly complicated to do in the EV setup. It takes into account the hepatic vein Doppler, intrarenal vein Doppler, and the portal vein Doppler.
Yes, yes.
Yeah. So, management investigations, we send normal CBC, ECG, TODI echo, IVC, lung ultrasound, BNP when the diagnosis is in dilemma, chest X-ray, and cardiac catheterization and pulmonary artery catheterization. Why pulmonary artery catheterization is important is basically it measures the venous oxygen concentration, the cardiac output, cardiac index, pulmonary capillary wedge pressure, that is pressure more than 18 mm Hg is clearly a left ventricular failure, and a right atrial pressure more than 12 mm Hg is clearly a right ventricular failure. If the pressure is more, pulmonary capillary wedge pressure is more than 18 and a right atrial pressure of more than 12 mm, then it is a biventricular failure. And something known as the pulmonary artery pulsatility index, which has been described quite recently, is basically this is the pulmonary artery pulse pressure, that is the difference between pulmonary artery systolic and the diastolic pressure divided by the right atrial pressure. If it is less than 1, it is strongly suggestive of heart failure, right heart failure. So yeah, management principles of cardiogenic shock, particularly we'll be discussing it in these topics: the etiologic therapy, that is etiology-wise management, optimizing the hemodynamics of the patient, improving tissue perfusion, improving the pump function, manage other organ dysfunctions, that is the cardiorenal syndrome, the hepatopathy, that is the congestive ischemic hepatopathy associated with it, and if refractory cardiogenic shock, then acute mechanical circulatory support if there is any evidence for it. So yeah, etiology specific management, these are from the American Heart Association guidelines. So it defines any acute myocardial infarction which presents as cardiogenic shock. This was the trial, the shock trial, that was published in NEJM in 1919. So it says that early revascularization with primary PCI in acute myocardial infarction related cardiogenic shock significantly decreased the 6 months mortality. Fibrinolysis is considered ineffective in such cases because the penetration of the thrombus will be reduced because of hyperperfusion. In patients with multivessel coronary artery disease, for a long time the guidelines used to say that immediate PCI of all the high-grade lesions was suggested. However, with the culprit shock trial, which was again published in NEJM 2017, it says that there is benefit 30-day improved mortality with only the PCI of the culprit lesion, also known as the PCI of the infarct-related artery. And optimal timing for the non-infarct related arteries, that is which have a significant high-grade lesion, is not not defined across papers. However, the AHA recommends to do it within the next 60 days. So yeah, coming to valvular heart disease, so we can see over there, this is a patient with a massive LA dilation, likely an MS. The J-shaped copy appearance of the mitral valve. So as we know in MS, basically the patient's mitral valve is closed, so there is no movement of the LV filling is affected because there is diastolic dysfunction. There is a dysfunction that is happening, and that will increase the left atrial pressure, that will increase the pulmonary capillary wedge pressure, and further progressing to right heart failure. So what happens? It is a preload dependent state. The problem over here is tachycardia. When there is tachycardia, the diastolic filling time decreases, the LV filling will be reduced. So target heart rate, when a patient of cardiogenic shock in MS with MS presents to the ED, a target heart rate should be around 60 to 80. Now how do we achieve it? So it is classified whether the patient has pulmonary artery hypertension or not. If the patient does not have pulmonary artery hypertension, you are sure, then the best drug to start is not noradrenaline, it's phenylephrine. Because it is a pure alpha agonist, it will cause reflex bradycardia. It does not have
a problem.
Sir.
Most of the time what will happen that you American this patient will come with atrial fibrillation. The pain will be on the higher side. So if you see the trials regarding rate, one thing is perfectly fine when the patient is on the dilatation of the heart rate. But it is 90. So there you want to maintain between 80 to 90. In 60 feet plus ज़्यादा हो जाता है कि ठीक है, 80 भी है तो ठीक है, 90 से कम रखना है.
So we can start phenylephrine at a dose of 0.5 to 2. Now if the patient has a pulmonary artery hypertension and TR, which we can identify by having a TR, then the better drug to start will be a vasopressin, obviously because it has a pulmonary vasodilation effect. Esmolol and amiodarone have also been suggested in the literature. Etiology specific management for valvular heart disease in case of mitral regurgitation. In patients of mitral regurgitation during the systole.
You are emphasizing something which is different from our day-to-day practice.
Sir.
The patient of regular heart disease, cardiology show you are suggesting that you should start vasopressin
Yes.
rather than norepinephrine.
Norepinephrine. In patients of MS, phenylephrine or vasopressin. If RV failure is there.
Basically, RV failure, जब RV failure होगा या biventricular failure होगा. Initially, what happened in MS? Initially, it is failure, just as failure becomes the failure, and then there is the RV. And definitely RV failure होता है. क्योंकि pulmonary arterial hypertension develop कर गया. ये फिर biventricular होता है.
Even if biventricular failure is there, तो phenylephrine will be a better choice. So, but it will cause vasoconstriction, it will cause a reflex bradycardia because it does not have a valve. So,
increased diastolic failure.
yeah, increased diastole. So, both of these drugs are potent vasoconstrictors. I will cover it later. They do not have beta-1 action. So, it will cause a reflex bradycardia. This is not a recommendation. So, they have not mentioned any recommendations. They just suggested this is to be done.
We can do some studies. Vasopressin versus
in patients of MR, there is a systolic dysfunction. During the systole, the blood goes to the, normally the blood will go to the aorta, but in this patient, the regurgitant jet will go in the LA, and that will further lead to a LV, increased LV load during the diastole. So over here, a normal to a slightly higher heart rate will be beneficial for us, and the main important thing is to have a reduced afterload. As you reduce the afterload of the patient, you will find that the more blood is being pushed towards the aorta, and the regurgitation jet will reduce. So in patients of cardiogenic shock, norepinephrine have been suggested, and as an additional thing, you can consider ionodilators like levosimendan and milrinol. They have a good afterload. They are dilated, so they will reduce the afterload. And IABP has been suggested by American Heart Association. We'll discuss what IABP is in subsequent slides. Specific to AS, aortic stenosis, again it is an afterload sensitive condition. Because of the stenosed wall, there will be a fixed outflow obstruction. So in these patients, if you reduce the afterload, if you give the drugs to reduce the afterload, that will be very detrimental for the patient because the outflow is fixed. Suppose some X amount of blood is going and you reduce the afterload, there will be a gradient, and that will further reduce the coronary perfusion of the patient. So normal vasopressors like norepinephrine, vasopressin, phenylephrine, anything can be used. Inotropes like dobutamine are suggested because dobutamine reduces afterload, so they are suggested only if the LV ejection fraction is reduced. In isolated aortic stenosis, the LV ejection fraction normally should not be reduced. In patients of aortic regurgitation, now aortic regurgitation, again it's a diastolic dysfunction. The more diastole you will give to the patient, the more will be the regurgitant jet. So our primary target over here is to increase the heart rate at any cost. So in a patient of AR presence in cardiogenic shock, will use pure chronotropic. They are suggesting to use pure chronotropic agent, that is epinephrine or isoprenaline. Isoprenaline obviously if the MAP is more than 60. And IABP is contraindicated in these patients. Now coming to hypertrophic obstructive cardiomyopathy, in these patients what happens is basically during the systole there will be a systolic anterior portion of the mitral leaflet over there and the interventricular septum which will kiss each other, and this happens when the LV volume is reduced. This will worsen. So our primary focus in these patients when they present in cardiogenic shock is giving fluids. Because when you give fluids, the LV will expand, the mitral wall will move away from the interventricular septum, and that will reduce the worsening. And this is about the preload, and for afterload also, you increase the afterload over here. You give drugs which increase the afterload, that is phenylephrine again and vasopressin. These are potent vasoconstrictors. They will increase the afterload. They will reduce the. They will keep the. Your focus is to keep the blood inside the left ventricle, so that the left ventricle is dilated. Bradyarrhythmia, tachyarrhythmias, those are a different scope of discussion, not in today's class. And management of cardiomyopathies with that is they mainly present as reduced ejection fraction. So increase the BP with using norepinephrine, and then maybe consider dobutamine, which we are usually doing.
pulmonary hypertension is entirely different. So in some of the patients, for example, interstitial systemic sclerosis, with extensive fibrosis, a little bit of vasoconstriction is there. The chances that it will improve by giving some vasodilators and these vasopressin is very difficult. Then again, if you see some of the shantings, so the shunts and they can help. In these conditions, these dilators can help. So हर आदमी में एक चीज नहीं ना, you have to again you have to see कि what is the underlying etiology. And accordingly, they say that it is better to see the efficacy by putting it pulmonary artery catheter and look how much pressure release is there. If you want to see, it should reduce the systolic pressure by at least 10 mm. Please further study. Cardiologist,
So choice of inotropes and vasopressors with this, because this is something which is available with us, maybe we should focus a bit over here. So adrenaline, as we know, works on receptors alpha 1, beta 1 mainly, and beta 2. Beta 1 is the main receptor. It is more of an inotrope, chronotrope and a dromotrope. Noradrenaline action only on alpha 1 and beta 1, no action on beta 2. Phenylephrine works only on potent alpha agonist, no action on beta receptors. We just focus on isoprenaline over here in the end, beta 1 action and beta 2 action. Dopamine we are not using, so this is another chart basically showing which the three ends, that is vasoconstriction, vasodilation and positive inotropy. Based on what your patient is, what is the etiology of the cardiogenic shock, you need to manipulate around this. So potent vasoconstrictor, phenylephrine, vasopressin. Worst bad part is increased pulmonary vasoconstriction, and good part is it will induce a reflex bradycardia of the patient. So when you want bradycardia, that would be a better choice. Isoprenaline over there in positive inotropic agent, better when there is pure bradycardia induced heart failure or something like that. Epinephrine again similar, dopamine medium dose, low dose that we have stopped using nowadays. When we move towards the vasodilation part, dobutamine, amirinone, milrinone, levosimendan, all those are inodilators. They will decrease the afterload, increase the inotropy. And NTG nitroglyceride, when there is like conditions like hypertensive heart failure, the primary focus is to reduce the afterload. So these are the trials that have happened in vasopressor inotropes. So the first was the Optima CC trial. This was to compare between norepinephrine and epinephrine for patients after of cardiogenic shock after myocardial infarction. Compared to norepinephrine, epinephrine led to more refractory shock. So norepinephrine was better over here. The SOAP2 trial, which was published in NEJM in 2010. Sir. So the SOAP2 trial, this is basically to compare comparison between norepinephrine and dopamine for patients with cardiogenic shock. There was no significant difference in rate of death, and dopamine was associated with greater number of adverse events, especially dysrhythmias. DOREMI trial, this was published in NEJM in 2021. This was between dobutamine and milrinone for patients with cardiogenic shock. There was no significant difference between milrinone and dobutamine. The SURVIVE trial, which was to compare between dobutamine and levosimendan for patients with heart failure. Levosimendan again did not significantly reduce the all-cause mortality. However, it had some better clearance with the BNP levels. REVIVE trial was levosimendan versus placebo. It was associated with greater improvement. Again, this had a very less, I think, some 70 patients in there.
Subset of patient, we will prefer Milrin.
So Milrin again it has a pulmonary vasodilator effect, so it goes kind of issues. That will be covered in So yeah, so coming to norepinephrine in cardiogenic shock, discussed already, alpha 1 beta 1 action, potent vasoconstrictor, increases systemic vascular resistance, planking resistance, pulmonary vascular resistance, increases MAP, increases heart rate. Choice for undifferentiated shock, cardiogenic shock, secondary to cardiomyopathies where the ejection fraction is the issue. First you need to increase the MAP and then focus on the ejection fraction. Patients with myocarditis, in valvular heart disease, specifically in patients with MR and shock secondary to MI. Starting dose is at 0.05 to 0.15 mics per kg per minute. Titration to be done as per the map of the patient. Epinephrine in cardiogenic shock, beta 1 action is most, beta 1, beta 2 and relatively less action on alpha 1. It is an inotropic, chromotropic, bromotropic effect, has a neutral effect on pulmonary vascular resistance. Increases MAP, increases heart rate. So it is the choice of drug for all patients who have bradycardia or where you want tachycardia. So bradycardia related cardiogenic shock in AR as we have discussed to reduce the diastolic filling time. Adjunct to norepinephrine in cardiomyopathy and MI related cardiogenic shock. Adjunct to vasopressin in RV cardiogenic shock. Increased risk of arrhythmias, increases lactate levels. Starting dose is 0.01 to 0.5 mg per kg. Dobutamine in cardiogenic shock, beta 1 and beta 2 action, inotropic agent, chronotropic agent, bromotropic agent, inodilator action, beneficial for cardiogenic shock in MR as we have discussed, choice of in cardiogenic shock with DCM, severe LV dysfunction. Chrono and Chrono. You have written Chrono. Oh, that was it. Chrono and Chrono. Sir, inotropy is basically to chromotropy is in the conduction. So starting dose is 2 to 20 mics per kg per minute. Phenylephrine in cardiogenic shock, pure alpha 1, potent vasoconstriction increases the systemic vascular resistance, increases the pulmonary vascular resistance. No beta action, therefore induces reflex bradycardia, beneficial, again not very strong recommendation but beneficial for patients in cardiogenic shock with MS and also tachyarrhythmia related shocks. Increased risk of worsening the pulmonary pressure in patients with PH. Titration should be done based on the map of the patient. And starting dose is 0.5 to 2 mics per kg per minute. Vasopressin in cardiogenic shock, it is works on V1, V2 receptors. Systemic vasoconstrictor, it is a pulmonary vasodilator. Many papers define it as a pulmonary vasodilator, many papers again define it as having neutral effect on pulmonary. There is no beta action, therefore there is reduced reflex bradycardia. So maybe in patients of MS with pulmonary arterial hypertension, it can be the choice. Beneficial for cardiogenic shock patients with right heart failure, PH, acute pulmonary embolism, can be used in patients with MS with PH, useful.
As a first line?
Yeah, maybe sir, we can try. There are no recommendations on anything. This is all suggestions.
Yeah.
Titration based on map. Starting dose. Usually, what we follow over here, the 0.04 units per kg per hour. The capping is only for septic shock. Here you can go up to 0.06 international units per kg per hour. Milrinone in cardiogenic shock. Per minute. Sorry, per minute. Milrinone in cardiogenic shock, mechanism of action, CAMP inhibitor and PDE3 inhibitor. So CAMP inhibitor will increase the contractility, PDE3 inhibitor will cause vasodilation. That's why it's and inodilator action, it has good pulmonary vasodilator effect again. Synergistic effect when used with epinephrine, beneficial for patients with cardiogenic shock of right heart failure, PH, acute pulmonary embolism. Can induce hypotension, obviously it is a vasodilator. Titrate as per the, it should be titrated as per the LV ejection fraction and urine output, not as per the map of the patient. Starting dose is 0.25 to 0.75 mics per kg per minute. Isoprenaline, beta 1 action more than beta 2, chronotropic action only, potential risk for hypotension. So basically not for cardiogenic shock patients, but to be used for patients with symptomatic bradycardia. I covered it for the completion sake. And AV block when you have a map more than 65. Titrate based on the heart rate of the patient. Starting dose is 1 to 4 mics per minute, can go up to 10 mics per minute.
Is it part of the ACLS bradycardia algorithm? Isoprenaline?
Isoprenaline is not included. Based on the 2020 guidelines, it's not there.
So in bradycardia algorithm, we are still using dopamine or epinephrine as in it is a last line.
That is what is they have suggested, but dopamine we do not use. In our practice, we use isoprenaline more.
But why? But AHA is not still recommending it because I also use isofranil. But AHA में नहीं है अभी.
So other organ dysfunction that cardiorenal syndromes, that is type 1 cardiorenal syndrome, which is acute cardiorenal syndrome. Type 2 acute cardiac condition which leads to an acute kidney injury. Type 2 is chronic cardiorenal disease which secondary to a chronic heart failure. And type 3 is acute nephrocardiac, that is AKI causing heart failure. Type 4 is chronic nephrocardiac CKD patient leading to heart failure, and type 5 is secondary.
So what we see in the emergency, we see everything, but then the most common will be acute cardiorenal heart failure due to AKI.
One and
the 2-1 chronic heart failure due to AKI.
4 also will see some chronic CKD. 4 is very percent.
नेफ्रोकार्डियक मीन कि नेफ्रो पहले हो रहा है फिर कार्डियक
CKD patients
है ना एक्यूट नेफ्रोकार्डियक एक्यूट लीडिंग टू एक्यूट ऐसा भी कुछ है
that is something which is rare.
इमरजेंसी में सब कुछ मिलेगा
Urinary
cardiac, nephro and secondary chronic and chronic. One and two is cardiac, related which is worsening the renal function. Third and fourth is renal function which is worsening the cardiac.
So this is useful for theoretical purpose only. Okay.
Type 3 is something which is related to urinary pericarditis syndrome. वो हमको इतना नहीं देखते.
Really, but my question is like, I don't know.
Just a way of classification.
I know it is a theoretical classification. My question is management wise, as an emergency physician.
So, per se, cardiorenal syndrome is not some diagnosis to consider. So only thing that has been suggested specifically for cardiorenal syndrome is giving diuretics. If you do not report the diuretic, thinking that patient has a cardiorenal syndrome. So something known as diuretic resistance. Why there is diuretic resistance in patients of cardiorenal syndrome? There are two things that happen. That one is the breaking phenomenon and one is tubular hypertrophy. Breaking phenomenon is one that happens, that is a short-term effect. So basically, when you start a diuretic, the sodium is lost, and that leads to a compensated upregulation of sodium receptors in the distal tubule, activating the RAS. So from when you give diuretic, the next time the response will reduce. So you will have to increase the dose of diuretic when you give the next time. And something that happens on a chronic way is the distal nephron segment gradually start undergoing hypertrophy and increased sodium transporter density, which leads to increased resistance of diuretics over time. So what can we do? Increase dose and frequency, add other types of diuretics, that is with loop diuretics, and consider metolazone, thiazide diuretics, and potassium sparing diuretics. Something about heart failure related congestive hepatopathy and ischemic hepatitis. Ischemic hepatitis is something which is where the ALT AST is more than 1000. Elevation of the INR also happens within usually 24 to 72 hours and comes back within 5 to 10 days. There's also something known as ALT LDH ratio that has been defined, which is less than 1.5 in patients of ischemic hepatitis. Whereas congestive hepatopathy, ALT AST will be normal, bilirubin will be higher, bilirubin will be more than 3 milligrams per less than 3 milligram per deciliter, but higher, and normal ALP levels. So intubation in cases of cardiogenic shock. So the thing to focus over here is the indication. So what we follow over there normally in the ED, refractory or severe hypoxia or hypercarbia, increased work of breathing that is not responding to NIV, that is the NIV failure. Refractory shock needing mechanical circulatory support, something again in US. Patients undergoing targeted temperature management or ECPR, that not very relevant for us again. RV failure or TAP. So one thing that we have to see over here is whether the patient is in RV failure or an LV failure. So when it comes to RV failure, your first thing is to delay intubation as much as possible, because even minimal peaks will cause will decrease the RV function further. So how do you adjust PEEP in cardiogenic shock patients? So if the patient is predominantly an LV failure, you can go with higher PEEP. You intubate, start PEEP at 5 to 10 and increase till up to 8 to 10. There is no problem. You want to clear the lungs, decongest the patient. Similarly, in patients with RV failure, you start with a low peak. That is, if you are intubating, you start with a peak of 2 to 3. You can go up to 5, but try to keep at the lowest level possible. Along with that, there is recommendation for considering use of pulmonary vasodilators, that is nitric oxide or inhaled epoprostenol, for refractory hypoxia. And management principles in RV cardiogenic shock: supply liberal oxygen, because the patient is your patient oxygen has vasodilatory effect. Avoid intubation, that we have already discussed. The map should be maintained above the RV systolic pressure. We discussed about the vicious cycle over there. So to break the cycle, the only thing you can do is you have to maintain the systolic BP of the patient, the systolic BP of the patient over the RVSP, and map should be 60 plus the central venous pressure of the patient. Inhaled pulmonary vasodilators, but you have to rule out an LV failure in that case, because that will worsen the pulmonary edema and patient facility.
There is hardly any vasodilator which has to be efficacy. ये कभी आनी है इसमें possibly multiple benefit कुछ दिखा नहीं है। लोगों को ये भी आ जाए कि उसका कोई benefit नहीं है। But understand, you have to understand कि patient को manage कैसे करना है। Oxygen is the most important.
So यहाँ पे वापस जाओ. So this is very important point about holding intubation in acute RV failure. Holding intubation is really very important, because as soon as you give intubation, patient will go into shock mode. They will worsen their condition. They will actually, what we see congestive heart failure. So they will have left LV failure and right LV failure. उसमें I don't know क्या peak कितना रखेंगे, peak उसमें बड़ा ध्यान रखना है.
You have to consider the whole plan. So the best thing is, let's say they suggest, so they suggest using the pulmonary artery catheterization and then titrating the pressure.
समझिए ED में हम बोल रहे हैं, ED में तो PEEP करेंगे, ED care पे सोचना है, focus on ED care. So ED care doesn't matter too much, but keep a low PEEP, withhold the intubation as far as possible.
Nitroglycerin has been suggested in many studies, dose of 0.5 to 3 mics per kg per minute. If the intended effects are not achieved, this was one study. It's not a very big study, single RCT. They have suggested that it should be stopped immediately. Assessment of volume status, whether the patient needs fluids or diuretics based on the compliance of the RV. So basically, patient with an RV MI, the RV is compliant. The RV is ischemic, but it is compliant. So you push in fluids. However, in a patient like massive pulmonary embolism or a pulmonary hypertension or sepsis with RV dysfunction, there the RV is not compliant. So fluids are not supposed to be given over there. You limit the amount of fluids that you give over there.
Massive P or massive fluid?
Fat or air. Yeah. When it's to consider mechanical circulatory support in right heart failure patient, when the cardiac index is more than 2.2 or the pulmonary artery pressure index more than 1. So coming to temporary mechanical circulatory support system, so this is considered when urgent hemodynamic stabilization is needed. Despite an optimal medical therapy, you are giving all the inotropes, you are using it, but the BP is still not improving. So is there any mortality benefit? IABP, Impella, Tandem Heart, VFM, ECMO, none of them has any mortality benefit. So yeah, these are the important trials over there. The IABP Shock 2 trial, which was for intra-aortic balloon pump versus medical therapy in patients of acute MI with cardiogenic shock. There was no difference in 30-day mortality. The IMPRESS trial, which was in 2017, it was basically to compare percutaneous mechanical circulatory system versus IABP. Again, there was no difference in mortality over there. The theme registry group, this was just 50 patients cohort study for Tandem Heart, which is a left ventricular assist device. Again, there was here there was some improvement. 74% had a 30-day survival and 66% had 180-day survival. It was just a cohort study. Protect 2 trial, Impella versus IABP. Again, there was no difference. Then came this danger shock trial. So basically what's happening in US is just to prove the benefit, they are trying each and every method possible, and I think this was the one trial. Yeah, this was the one trial where they have found out benefit. So this is considered as a landmark trial in US because they have a justification to use this now. So it is basically microaxial flow pump. That is our
I required Denmark
yeah.
studies in Denmark.
No, but the guidelines now
Many work, they work together. It's published in New England Journal of Medicine from Harvard.
So 355 patients with STEMI and cardiogenic shock, Impella versus standard care, Impella plus standard care versus Impella. 180-day mortality was 45% in Impella group and 58% in standard care group with a p-value of 0.04. So it reduced the 180-day mortality in patients with STEMI and cardiogenic shock. So yeah, coming to inter-aortic balloon pump. So how does it work? Although not relevant in our setup, we'll just discuss it in brief. So this is the balloon pump. You see a balloon over there. You push it through the femoral artery and proceed it up to the into the aorta around 2 to 3 centimeters below the subclavian artery. Now what happens is during diastole, the pump will inflate. So it will give an afterload that will increase the coronary perfusion of the patient, and during systole it will get deflated. So it will reduce the afterload and the myocardial consumption, cardiac output, etc. will be increased. So in patients that we have already discussed, in patients of MR it will be beneficial because in MR during the systole this will get deflated, it will decrease the afterload and will reduce the regurgitant jet of the patient. So indications, myocardial infarction as a bridge for CABG, cardiogenic shock almost exclusively used in US, high risk PCI as a bridge to maintain the coronary perfusion and while weaning of the patients from cardiopulmonary bypass. Contraindication is acute aortic regurgitation, acute aortic aneurysm, severe peripheral artery disease and coagulopathies. Left ventricular assist device. What is a left ventricular assist device? It simply takes the blood from the left ventricle. There is a pump over there which is connected to a controller. The controller is connected to a battery. The pump will work and it will push the blood into the aorta, just bypassing your left ventricle, easing the load of your left ventricle. So there are something known as temporary VAD and a durable VAD. Temporary VADs are used for short term, percutaneous or surgically placed. Bridge to recovery, and power source is external, whereas durable VADs are long term. You can discharge the patient on them on durable VADs, and they have to come for frequent monitoring for the battery. That's it. So ECMO in cardiogenic shock, review of the literature. So there was these 3-4 trials that have happened. ECLS shock trial, which was published in NEJM in 2023, extracorporeal life support versus standard shock in patients of cardiogenic shock. Risk of death, 30-day death from any cause was not lower as compared to in the ECLS group. ECMO versus ECMO CS, immediate ECMO versus not immediate ECMO, no difference again. Unload ECMO trial, that is early, they did an early left ventricular unloading. So they pierce the left atria because the left ventricle is not working, so it will go back to the left, the pressure will go back to the left atria. So they will just put a septum, pierce the septum and try to offload the ventricle over there, and again there was no reduction in mortality. The Euroshock trial, that trial
Septroscopy is very common.
Yes, sir.
Pediatric just to release the pressure to
septal function.
But none of this will work with the cardiogenic shock patient because heart has to recover. So you can use it as a bridge therapy, bridge to recovery, like myocarditis patient in shock, you can put the patient in ECMO and pray to God give cardiac mortality. Then rest to
Despite having all these things and the mortality
then bridge to destination, then we have to so randomized is permanent होता है, that is bridge to destination therapy with the
So in this, like any of these trials,
No,
no mortality except for
danger trial.
What is that?
Impella, basically an ventricular assist.
नहीं पहला था
Impella, which is a ventricular assist.
Which is a kind of LVAD. Impella discuss थोड़ा bit.
So ongoing studies that are going on, one is an ACCOST trial. This is basically a novel antibody called adresizumab, non-neutralizing antibody that regulates adrenomedullin level. What is adrenomedullin? It is a hormone that has shown to have anti-apoptotic factors on cardiomyocytes. in an acute MI mouse model. Anchor trial, it is VA ECMO plus IABP plus OMT versus OMT alone in acute myocardial optical medical therapy.
Usually जब आप ये पे डालते हो there is so much left ventricular stunning कि आपको इम्पेयर डिवाइस डालनी ही पड़ती है। ये पता नहीं क्या
So there is somehow I think trying to prove some benefit. There is a hypo ECMO trial, something different that tried to induce moderate hypothermia versus strict normothermia in patients undergoing VA ECMO. Again, no difference in outcomes. Sir, I think even after all of these trials, even in the US, the mortality is still around 47%, and India, mein obviously there are no studies per se, but some small here and there articles have said that it's around 40%.
Just stabilize the patient for a few hours and then transfer the patient for that's it. Otherwise, your patient will not survive.
So question is, in my setting, in my ED, most patients are rheumatic heart disease, okay? And I have CBRMS versus MR, which the Western world doesn't see so much. So CBRMS, sir ने भी बताया, CBRMS, which is where you have diastolic murmur, which is where obviously this is a large number of our patients. How do we handle that in terms of fluid management and inotropic support? So वो एक बार रिवाइज कर दो।
So just trying to reduce the heart rate is what have been said in the literature, because reducing the heart rate will increase the diastolic time. So that's why they have suggested phenylephrine or vasopressin. These are vasoconstrictor, do not have beta 2 action, so cause reflex tachycardia. For basically. So that is why sir we will try to change that, sir.
So ये evidence बहुत बड़ा नहीं है, नहीं but फिर भी मतलब सर कुछ भी evidence है So what is the suggestion of cardiology? What is, because they are also seeing.
So यहाँ तो हम सब patients को
level of evidence क्या है?
Sir, this is not evidence, this is not recommendation, sir. ये बस उन्होंने American Heart जो association का जो guideline है, उसमें उन्होंने बस suggestions करके लिखा हुआ है, table बना दिया है कि how do you manage cardiogenic shock. This is not evidence. There is no recommendation. This is not a recommendation, sir. उन्होंने बस suggestions दिए थे. Maybe you can consider this vasopressin. It's completely based on physiology.
Are there any studies for phenylephrine and vasopressin?
No, phenylephrine or epinephrine are only paper studies.
Just phenylephrine and just vasopressin.
This is the second largest.
MR में our main target is to reduce the after fashion, so that the regurgitant jet is reduced, the blood goes to the aorta. तो उसमें they are suggesting एक बार आप norepinephrine बढ़ा दो, and then you can start milrinone, levosimendan और जो भी करना है. इसका beta blockers. Both levosimendan and
cardiogenic shock.
even levosimendan is beta blockers.
So if you are seeing MR, norepinephrine यहाँ पे भी first लिखा हुआ है और हम भी norepinephrine देता है, but evidence I was saying नहीं होता. ये suggestion है कि ये भी recommendation है.
Sir, it is physiology based, sir.
There is clear-cut suggestion, the recommendation for cardiogenic shock.
Yeah. So some subsets में जो हमारा subset है वो MS है, उसमें हमने बता दिया कि vasopressin.
ये चीज US में से कॉमनली है ना, जो मेजर स्टडीज हैं.
Study नहीं कर रहे हैं. स्टडी वो कर ही नहीं सकते भाई उनके पास security नहीं है तो स्टडी करना
So this is something which is completely different. AR manipulation, decreasing the diastolic time as much as possible because real time jet कम होगा तो उसके लिए increase the heart rate. You target a heart rate of 130. So you use only chronotropication. That is what.
क्यों जैसे टैकीकार्डिया करेंगे
टैकीकार्डिया करेंगे तो डायस्टोल कम हो जाएगा. डायस्टोल कम हो जाएगा तो रियल टाइम jet आना बंद हो जाएगा. तो
और एमएस में होता है एमएस में आपको लोड करना है ब्रैडीकार्डिया कराना
इसमें टैकीकार्डिया तो इसमें तो एपिनेफ्रिन और आइसोलेटिन लिखा है
हमारे लिए ये तीन स्लाइड द मोस्ट इंपॉर्टेंट स्लाइड
सर डी स्पेशल डायनेमिक स्टडीज हमारी कंट्री में हो सकता है यूएस कंट्री
स्टार्ट करो You covered what we see in IIT and also what we don't see in IIT.
So mainly we got the idea after US only. हम लोग ने वहाँ पे made a long choice. We blanketly not.
Actually, sir, we burnt our fingers in वो swimming during से ना fat embolism में acute heart failure में we gave norepinephrine. उसमें हमारे 0.5 marks